warm welcome on the day 3 of the 6th Annual National Conference of PICU Foundation FEFCON 2023. It's been yet another successful journey so far. The last 2 days, we had a fantastic scientific feast from all the speakers, chairpersons, faculty joining and giving the clinical pearls. We have had more than 67,000 registrants joining in across India and as well as international foreign countries as well. Thank you very much. And without wasting much of our time, we will start with the first session of the Pediatrics Hall. To start this session, we have a chairperson, Dr. Anand Kesavan sir. Dr. Anand Kesavan sir is also a key member, guide of the Fever Foundation. Is one of the founding members of the Fever Foundation. Thank you very much, sir, for all your support, guidance, and because of you, we are here conducting the 6th Annual National Conference of Fever Foundation. Also, to give just a small bit of background, though everyone knows Dr. Anand Kesavan sir, he is the professor of pediatrics at GMC Thrissur. He's also been the national vice president IAP 2020. He's also been across various IAP central positions. Also, he's been academically oriented with multiple books, chapter contributions, and also numerous publications to his credit. Anand sir, it's over to you to moderate the session of Dr. Dhiren Gupta sir. Dhiren Gupta sir, thank you very much for joining in, and it's over to you, Dr. Anand Kesavan sir.
Very good morning. At the outset, we would like to thank the Fever Foundation for the excellent conference organized for the last 2 days. Today also we had heard in the morning. So now the topic for discussion is radiological clues in diagnosing prolonged fever. Just now we heard about lab investigation. I think Dhiren Gupta was not there. Anyway, the positive and negative aspects, pitfalls, advantage of lab investigation. Anyway, it will take 2 to 3 days or more than that one to get an exact result. There are so many errors may happen with the lab result. We have to wait 3-4 days. Then antibiotic, antiviral, all confusing. Radiological investigation is one of the best tools in the hands of a clinician after careful clinical examination. We got chest X-ray, ultrasonogram, MRI, and CT scan, and other modality of investigation. But I think it will vary, individual variation in interpretation of the result. That is one problem with the radiological investigation. And all investigations are not freely available in all area. Okay, that we can to understand, we can bear. But the thing is that I think one investigation which came very good progress is that ultrasound investigation, especially in the PICU settings, and lots of application for ultrasound. And I think even our residents are using it, very much utilizing it. And also we are thinking about the overusing of radiological investigation. In one side, we are to limit our overuse of radiological investigation also. So to talk about all these things, we got an excellent speaker, Dr. Dhiren Gupta, the corona man. I think he's everything, especially with corona. He's from prestigious institute, Sri Gangaram Hospital, New Delhi. He's a PSU fellowship teacher, a diploma in pediatric respiratory medicine and European respiratory medicine, and a focus fellowship. And he also received so many awards, Vishishta Chikitsa Award from Union Government, Coronavirus Award from WHO, and award for his good service in Corona from IEP Delhi, Goliath, Carol Bag, Uttar Pradesh. And also he is a teacher for IEP Fellowship in Pediatric Critical Care. He is Chancellor of Pediatric Critical Care College 21 and a chairperson of the Pediatric Critical Care IAP. He written so many chapters and also contributed chapters in books and also written more than 50 publications in international journals. So we are lucky to have discussed an important topic by an important person. So I invite Dr. Dhiren Gupta to deliver his talk. Over to Dhiren.
Good morning, everyone. Thank you, Dr. Anand. And in fact, it's a privilege, and that as you already have introduced, the topic is very important. And over the time, we have found that that many of the tests are available, not immediately available to us, and they take time, and even some of the lab tests are not available. But radiological tests are available, and you can move ahead, especially with the availability of focus over the time. Today, next 15-20 minutes, I am going to talk about some radiological clues when we are dealing with prolonged fever. Most of the patients which I am going to show are OPD based because in ICU, it is not very difficult to get the test and difficult to get the clues. But in an OPD basis and indoor patients, if patient is having prolonged fever, then at times it is very difficult. And whenever we get any radiological clue, we need to know what are the soft markers on these radiological clues. At the end of talk, you will find that sometimes radiological clues also can misguide. Aim in this presentation, I've tried to choose those patients where there are not very clear localizing signs. Of course, patient is having either continuous fever or recurrent fever, and of course, no dermatological signs, major dermatological signs. So the radiological and other investigation plays major role in all these patients, which I'm going to show you. When we talk about prolonged fever and radiological positivity signs, infections, of course, tuberculosis is the primemost. Some radiological clues in brucellosis like hepatosplenomegaly on ultrasound abdomen. Some infections like fungal, parasites. There can be infiltrative disease, malignant disease like lymphoma, leukemia. And nowadays, there is a surge of non-infectious inflammatory disease. They can be allergic, they can be hypersensitive diseases, they can be rheumatological disease. And as already Anand sir has told us that main tests to start with are the chest X-rays and the ultrasound. We try to avoid CT scans because it needs a lot of radiation and MRI needs sedation. So our primary focus is primary test which we are going to focus is the chest X-ray and ultrasound. Let's start with these cases. First case is 12-year-old. She's an asthmatic, poorly controlled asthmatic. So obviously the child must be having cough. But since past 3 months, patient is also having fever for past 2 months specifically. And these are the three X-rays of the same patient. And you can see on the first X-ray, there are some shadows on the left parahilar. Then on the second X-ray, these are the left side infiltration and right side also middle zone infiltration and also right paratracheal. Then the third X-ray, again the left side infiltration, but different from the second one, and some right middle zone and right upper zone infiltration. Now, whenever we view these type of fleeting shadows, the national disease comes into mind, that is tuberculosis. But the difference between tuberculosis and the disease like ABPA, allergic bronchopulmonary aspergillosis, is that in ABPA you find transient shadows, fleeting shadows. In tuberculosis, what happens most often, there will be fixed shadow. Either that will be little bit less or more, but that is going to stay there. So the first diagnosis in these type of patient where there's a fleeting infiltrate, we think of ABPA like diagnosis. And of course, we are going to get a CT scan. CT scan, that classical CT scan is a central bronchiectasis. That is a classical one. But once the disease is advanced, you may find this finger in glove sign in the lung that is known as toothpaste shaped opacity. As you can see, this is a typical toothpaste shaped opacity. And they are more prevalent on the CT scan. On CT scan, also this finger in glove sign has been described. You can see this is a hyper enhanced opacity. This is a mucus which is actually contains a lot of HTU units when we talk about CT scan. But not all fleeting shadows are ABPA. There can be multiple differential diagnoses, especially if patient is presenting as a pyrexia of unknown origin. Now look at this patient, a 14-year-old from Agra, fever and cough for 5 months. Cough was not that much, but fever was persisting for past 5 months. In fact, child was having fever for almost 1 year intermittently, and patient was on ATT because somebody noticed cavities on the X-ray. You can see the cavity; these are rounded cavity, and it is thickened wall. On the left side, there are infiltrate, pericardiac infiltrate, must be lingular lobe. Also, patient received steroid for 10 days in between. And as I told you that the shadows disappeared in between. So there was an X-ray where shadows were very minuscule, and one X-ray I'm not having where shadows actually disappeared. So chest X-ray absolutely became normal, and patient was on ATT. So there were differential diagnosis. Probably patient had tuberculosis, recovered, now again had tuberculosis. But there was something else. It was the steroid that led to disappearance of the shadows, because what we found, other than the lung, we found there were lot of petechial hemorrhages, and also these were palpable purpura. CT scan also showed lot of nodules. There was no cavity in these nodules, and bronchoscopy also did not reveal any AFB. There was ground glassing appearance, as you can see, and there was a septal thickening. So looks like crazy payment also. So ultimately, this patient was diagnosed to have Wegener's granulomatosis. So any shadow, especially in adolescent female, one should look for something non-infectious, maybe just inflammatory. Now look at our national disease, that is tuberculosis. The classical radiological picture when we talk about tuberculosis is lymphadenopathy. As you can see in this patient, 9-year-old with fever for almost 3 weeks, weight loss. And if you look at X-ray, the radiologically, right paratracheal, there are the shadows. These are the opacities. Right hilar rounded opacities. These are, you can say, classical manifestation of tuberculosis, especially in pediatrics. And in this type of patient, if you find Montaux positive, but of course, nowadays we go for AFB. It means we try to produce microbiological clue before we start ATT. Since gastric aspirate was negative, so we went ahead for endobronchial ultrasound, and gene expert was positive. To our surprise, it was rifampicin resistance. So that gives an importance of these type of tests of microbiological tests, which gives us sensitivity also before we start ATT. Since this presentation is all about radiology, this is an B X-ray, which is after 6 months of ATT. So give us an impression. Look at the hyla. The change in the opacity, the rounded opacity now actually normalized. So this one is normal hyla. Left side was normal and continue to be normal. Now, hyla is very important landmark when we talk about tuberculosis. So one slide I would like to spend on hyla. Hyla, normal hyla means it is the impression of the pulmonary artery. This is the right pulmonary artery, this is the left pulmonary artery, and it is conical and branching. That is actually normal hyla. And when patient improve, if you look at the right side and left side, it was conical branching. It means normal hyla as compared to the first X-ray where they were rounded lymph node. But all hilar enlargement again is not a tuberculosis, which you will get impression by looking at this patient, a 10-month-old who presented with fever for 2 months and receiving ATT for 1 month. Despite of giving ATT, receiving ATT for 1 month, look at this X-ray. Patient persistent to have fever. There is a left hilar enlargement, right paratracheal, right hilar, though it's a rotated film, but also there are small nodules like miliary, little bit bigger than the miliary shadows. And if you look at the CT scan, slight necrosis in the subcarinal and right paratracheal, but less necrosis than a tuberculosis. And also, if you look at axial picture of the CT scan, there was a right paratracheal large lymph node, and on lung window you can find small shadows there, and small nodules, and with ground glassing and mainly some consolidation also. And to our surprise, it was not resistant tuberculosis. Actually, it was cryptococcal neoformis, and patient was not immunodeficient. And till date, we had around 6 patients of cryptococcal, and none of the patient actually had immunodeficiency. Now we move to other set of patients. Look at this child, 10-month-old child who presented with fever. This was must be a decade back or 12 years back. Fever for 14 days, cough for 10 days, and treated as an asthma. Patient presented to us to respiratory failure. And if you look at all the lung zones, there are fluffy shadows, looks like staph or some air. Patient is going to land up in ARDS. Patient was significantly hypoxic, required intubation. But on the X-ray, one of the X-ray showed some osteolytic lesion in the hand and in the forearm bones. And that was very evident on when we went ahead specific X-ray. We got a specific X-ray of the hand bone. There was an osteolytic lesion. Then we thought of something like Langen cell histocytosis, and we ordered the bone scan, and we were able to demonstrate clear-cut osteolytic lesion in the skull, and also on the CT scan, it was the same picture, almost honeycombing of the lung. And this patient was diagnosed to have Langen cell histocytosis. There was no superadded infection like staph. Again, Langerhans histocytosis is not that uncommon and can present with pyrexia of unknown origin. And the radiological signs, especially on the chest X-ray, most of time it shows multicystic lesion. Look at this patient. This one is a patient who came around to 1 month back, a 2-year-old with pyrexia of unknown origin for 2 months, and patient presented with spontaneous pneumothorax as it is evident on the X-ray. And this patient, once tube was inserted, the lung got expanded, and we found small opacity on the right side of the lung. And ultimately, this patient was also diagnosed to a Langen cell histocytosis. Unfortunately or fortunately, this patient didn't had extra lung region, extra pulmonary lesion, and there was no lesion where we could get the biopsy. So we got a lung biopsy, and patient is being under treated as a case of LCH. Now patient is getting better. Sometimes when we talk about some shadows on the X-ray, doesn't mean it is going to originate from heart or from the lung. It can originate from elsewhere also, like from mediastinum below the diaphragm. And this is a good example of that. This patient came to me around 12 years back, 1-year-old patient with failure to thrive, often on vomiting and fever, low-grade fever for past 2 months. When we got an X-ray, there was no major lymphadenopathy on the left side or right side. But what I could find that there was a opacity, means radiolucency behind the heart. So I thought of there's something happening in the esophagus. So I got a lateral view, and on lateral view, as you can see, this is a left lateral view. This is the cardiac shadow. This is retrosternal view, which is showing us, the thymus. And this one is your trachea. This one is your trachea. This is your hilum. But behind the trachea, this is a fusiform, you can say, opacity. Looks like esophagus and likely achalasia cardia, which was further proved on barium swallow. As you can see, achalasia cardia with dilated esophagus, and also on CT scan and endoscopy also showed the same thing. Many times, some opacities at the lung zones are treated as a pneumonia. Now look at this patient, 2 year, again failure to thrive with persistent vomiting and recurrent fever, but never had cough. But every time, because of this right parahilar opacity, patient got admitted 3 times and treated as a case of pneumonia. But unfortunately or fortunately, this shadow was not originating from the lung, as you cannot see the right side diaphragm. And actually, this patient is having some opacity which is emerging from the abdomen and is entering into the chest. This was a patient of hiatus hernia. So not uncommon to have lung regions occupied by the other areas like esophagus and the abdomen. Now look at this another child, a 6-year-old with fever for 2 months, weight loss. So you think of tuberculosis. And on the X-ray, you can see on the X-ray, left side hemidiaphragm is not visible. So very likely it is the silatoing of the left lower lobe zone problem. And this patient had lower lobe pneumonia. As well as if you look at the heart, the shadow of the heart is like an inverted bottle. So the cardiac shadow is not absolutely normal. If you look at the right costophrenic angle, that is also obliterated. There must be some effusion, and we were thinking of tuberculosis as the first diagnosis. So we went ahead and we found that it was pleural effusion. It was a pleural effusion. Also on chest wall, there was some swelling, and it was extended with the pleural. So this is a pleura, this is your pleura, and this is the chest wall. And actually, there was some opacity, you can say an echoic opacity on an ultrasound, and which was showing extension towards the pleura, or indirectly there is some pleural effusion which is getting extending to the chest wall. On CT scan, we could find that there is some problem on the chest wall also, other than the pericardial effusion. So, as focus is readily available, so we went ahead and did a biopsy. You can see this biopsy, ultrasound biopsy is being done. This is a needle, and we could aspirate the fluid of the chest wall abscess, and it ultimately it was Mycobacterium tuberculosis, which was detected. It was low, but it was not resistant. So there was no resistance. Now we move to another set of patients who presented with pleural effusion, but it was not tuberculosis. This was again around 12, 13 years back. This patient, 12-year-old patient, referred from Gwalior as a pyrexia of unknown origin with normal X-ray, with normal ultrasound, with normal Montauk, everything normal. Patient presented with the hypotension at 6:30 a.m. in the ICU. I was there. So, as a protocol, we did an echocardiography. On echocardiography, to our surprise, not only we find pericardial effusion, but there was some tumor. There was a hyper echoic shadow, which was probably between the right atria and the right ventricle junction. And the patient had low blood pressure. We went ahead, we put in the needle, and it was all malignancy. So pericardiocentesis was done next 1 hour, and it was all malignancy. So it's not an uncommon to have same age group, similar presentation, but different outcome. So microbiological clue definitely should be done before we start tuberculosis. So radiological shadows give us some idea what is happening, but it doesn't give you diagnosis in many instances. Look at this patient, 2-year-old male, who is a case of VSD with fever for 12 days, and there is no focus. As we did focus, and we found that there is a vegetation attached to the VSD, and this patient actually had fungal infection, which was treated. This is another 14-year-old who presented with fever for 2 months. Look at the patient, he's irritable, he's in encephalopathy, and right upper limb is gangrenous. Though other limbs also showed partial obstruction of the arteries, on focus, that is echocardiography was done, and there was a thrombus inside the left ventricle and the left atria, and that thrombus was moving out, and it was a hypercoagulable state, and ultimately patient got better. Now look at this another patient, 12-year-old, same age, fever for 2 months, and significant tachycardia. Patient was admitted. Before we got blood reports, we put an ultrasound over the eye, which we do in any patient who is irritable, where there is some decrease in the consciousness. And on ultrasound eyeball, we found that on the posterior wall, there is some, you can say, infiltration in the retina. And though optic nerve sheath diameter was little bit on the borderline side, that is normally it is 0.45 and it is 0.56. So then we got a report of total leukocyte count. It was 4 lakh plus, and it was diagnosed as a case of acute myelocytic leukemia. Now we move to another set of patient. A patient 8-year-old is a case of dengue, who had typical course of dengue, but didn't improve on 6th day. Instead of improvement, patient land up in liver failure and again started having fever. So past 5 days, that 12th day of the disease process, patient is intubated, is ventilated because of encephalopathy. And on 12th day, when the fever was persisting for 5 days, on 8 a.m., I found that there is some swelling of the right eye. Like patient on multi-organ dysfunction with liver dysfunction, we always feel there must be hypoproteinemia that is leading to the, this type of swelling. Because we have got a focus, that is ultrasound probe is there, so we put in a probe on the right side. This is the normal ultrasound eye, this is normal eye globe, this is normal optic nerve sheath diameter. But in this patient, what we found that hypoechoic shadow rather than this optic nerve sheath diameter. And so we further investigated. Next hour we got an MRI done, and what we found, lot of infiltrate. lot of infiltrate, and actually this patient had pansinusitis, and this is all fungal infiltrate. And very unfortunate, next 2 hours, pupil became fixed and dilated, and you can see next 6 hours, whole of the face became necrosed, and ultimately we lost this patient, and even management looks futile. Now we move to the last set of patients. We are going to talk about something like fever presenting as an aspiration pneumonia, or aspiration pneumonia presenting as a fever. This is a 4-month-old boy who presented with cough, fever, and failure to thrive. Patient had some birth asphyxia, mild birth asphyxia, tone was less. There was an inspiratory stridor when we used to agitate this patient. X-ray did not reveal. CT revealed some ground glassing and also infiltrate on the posterior aspect, which normally indicates likely we are dealing with some aspiration. So we went for swallowing study. We did video fluoroscopy study, VFSS. We asked the patient to take barium inside, and we look at the video. On video, not only going into the esophagus, but something was trickling into the trachea and into the bronchus. So there was definite sign of aspiration in this patient. Then we did fibro-optic endoscopic evaluation of the swelling. So we inserted the endoscope in the nose, and in the nose we put in a we kept bronchoscope in the oropharynx, and asked the mother to give something to drink, like a milk with methylene blue. And what we found that this diagnostic test was inconclusive. We could not prove that feed is going into the trachea. But on lavage, what we found is a huge number of cytomegalovirus, and as well as lipid-laden macrophages, that is more than 25%. That is an indirect sign of aspiration pneumonia. Now, beyond CMV, we take two patients who had almost similar presentation. The first one, that is the A1, is 10-month-old, where patient was having cough for 2 months, fever off and on. And there was a history of oil installation in the nose, and this patient came from the Bihar, right? And on X-ray, we could find lot of infiltration and upper and middle zone. This is a patient number B, who is 22-month-old from Allahabad, with history of forceful feeding, and again cough for 2 months and fever off and on. And they were, granulomatous sort of infiltrate, looks like rounded shadows infiltrate, looks like tuberculosis, as we a sort of confluent miliary shadows. We went ahead CT scan in both of the patient, and we did not find any other sign of tuberculosis in these two patients. In the first one, we could see some signs of leukemia pneumonia on the CT scan, where the Hounsfield unit was very high. That is very classical of lymphoid pneumonia in adult. But in pediatric, the CT scan many times is not very classical because the amount of lipid injection is very less. On the B case, what we found, the centrilobular tree in bud nodule. But we went ahead with the bronchoscopy in both of the patient. In none of the patient we could prove anything. And ultimately, this B patient was a case of hypersensitive pneumonitis because of the lentil hypersensitivity. In the B number patient, we gave steroid. In A number patient, we just gave antibiotic. We stopped that oil installation habit, and patient become normal over next 3 months. Now, friends, when we talk about, yeah, this was the patient of the way the patient is coughing, and this one is the patient who was a case of hypersensitive pneumonitis, and now both are absolutely fine. To conclude, this was a very longish presentation because there are many cases with radiological clue, but in 20 minutes, I thought that to share these type of patient of various presentation and various clinical manifestation. Now, to conclude my presentation, I just want two things. One is the most important thing, that when we talk about radiological shadow, it has to be clinical, radiological, and pathological correlation. Sometimes radiological as well as clinical, this combination can be of different types. Means pathology may be different, but radiology and clinical presentation can be same. So this type of correlation is very, very important, especially in the era of such a developed microbiology. The very important thing is the discussion with the radiologist. Not only you have got this CT scan, you want to discuss with the radiologist, also give feedback to radiologist. Most of the time we feel that, okay, radiologist is a paramedic worker. He doesn't know about the patient, but it's your duty to discuss discuss the clinical finding of the radiology, what you are viewing. In fact, before you give instruction to particular type of CT, you should always discuss with the radiologist. And very important is to give feedback to the radiologist. Only then he is going to take interest. So thank you very much for the organizer to give me this topic. And thanks for the patient hearing. Thank you very much.
Thank you, Dr. Dhiren Gupta. It is a very wonderful presentation starting from Wegener's granulomatous, different types of tuberculosis, mucormycosis, and also different types of presentation also. Very, very important. So, Dennis, you mentioned about the one pericardial effusion with malignancy. What is the cause for malignancy?
Yeah, that was myxoma. That was around 15 years back. So I took that case yesterday only. So that was likely myxoma, and the patient was taken to theater next 24 hours and was operated successfully. The patient is absolutely fine now.
So you are seeing so many cases of fungal infection with a normal, without any immunodeficiency, because you mentioned about a cryptococcus. So,
yeah,
very common. Or it is due to malnutrition. What was a patient?
I think malnutrition was secondary because height was okay. There was some failure to thrive, but we could not. This patient had everywhere there was cryptococcal, including bone marrow, including urine. Everywhere there was cryptococcal. And we tried to check the immunity, acquired immunity, and inert immunity. Means we could not find any clue about the immunodeficiency. Following that, I think we had 5 cases of cryptococcal. None of the patient we could find immunodeficient disorder. So over the time, what I have seen, what I have witnessed, that fungal infection is happening to immunocompetent patients. Also, sometimes these patients have actually received steroid, and as you rightly said, during COVID, post-COVID, we have seen that there was a rise of fungal infection, but we have seen mucormycosis much before the COVID, during dengue with hyperferritinemia and many hyperferritinemia syndromes. They have some acquired immunodeficiency and they tend to acquire these fungal infections.
Thank you, sir. If there is any further question from the audience, Dr. Krishna.
Jagdish Chinappa, sir, good morning.
Very good morning,
good
sir.
Afternoon, good morning. I think. Yeah.
Good afternoon. Good afternoon. Not yet good afternoon. So I was just going
Vasudev, sir, good morning.
I was just going to comment that I thought the match is only going to start at 2:30, but I think you started with a sixer even now, early in the morning.
Sir, thank you, sir. Thank you.
Actually, so that was one small comment I had, and I think sometimes I know that you are a very experienced clinician, come radiology specialist. But many times we also need to consult the radiologist before we image, because we need to decide which is the correct modality of imaging.
Exactly, sir. Sir, exactly. I commented on that. Before you order for radiology, talk to the radiologist. Correct, means correct. I give you just if you permit me 1 minute. It was 25 years back. There was a patient with multi-system lung involvement. I got a CT scan. And I got a CT scan, shifted patient back to the ICU. Then the radiologist, that time they were Dr. Vora, I still remember the name. He called me. Dr. Dhiren, what is on the skull? What is on the scalp? And I was ashamed that patient was with us for 7 days. I did not examine the skull. I did not examine the scalp. And there was seborrheic dermatitis, and that was a case of LCH. Since that date, I never forget to examine the scalp of any patient with lung disease. So probably we always feel that these paramedic branches, people are stupid. We are, superior because patient belongs to us. But if you try to have good matching and good communication with them, I feel that you will be better clinician for, for future.
Thank you, sir. Thank you so much.
Krishna, any questions in the chat box, or we cannot see that one?
Sir, right now I don't see any questions. Once we get it, we'll post it to Dr. Dhiren sir and we'll get the responses.
Yeah, I think it looks like very complicated presentation, so nobody dare to ask any question, right?
Anyway, you are dealing with the corona and you are dealing with X-ray. What about after 3-4 years of corona? Any persistent problem with the corona still you are seeing in children?
I would say in children there is no residual effect, right? There is something look like non-COVID, and I was part and parcel of WHO, one of the recommendation about the long COVID. But I did not find long COVID in Indian population. Somehow I found that pediatric age group is the recovery is very fantastic in these patients. In adults, in many of the adults, because of the steroid, because of some other comorbidities, they are having persistent side effect. But one tendency in human being has happened. Whenever, even today, if they get some problem, they always say it is all because of COVID. I was suffering from COVID. That's why I got hypertension. Because of COVID, I got, in India, we always try to find some excuse why we got the disease. So probably not all the COVID patients got some residual problem. Most of the pediatric patients who had COVID actually are absolutely healthy.
So thank you, Dr. Dhiren Gupta, sir, and thank you, Fever Foundation also. If there's no further question, we'll wind up the session. Thank you once again. Over to
Thank
Krishna.
you, sir. Thank you.
Thank you, Anand Keswan sir, and thank you, Dhiren sir, for the wonderful session there on the radiological clues. Moving on to the next session, we have Dr. Professor Ashwini Kumar sir, Sood sir joining in, and we have the speaker in as Dr. Srija Sugunam ma'am. Welcome, ma'am. Also, at the outset, I'd like to thank we have the teacher of teachers, Dr. S.P. Balasubramaniam sir. Sir, thank you for joining in, SPS sir. And also we have a few other faculty joined in. A warm welcome to all of them. Dr. Professor Ashwini Kumar Sood, sir, welcome, sir. The session is yours. Can I have the CV of sir, please? Yeah. Dr. Ashwini Kumar sir Sood is the professor of pediatrics at the Indira Gandhi Medical College, Shimla. He's been the president HPNNF, president Haryana State Chapter. He's been the chairman advisory board for pediatric TV under NTF on NTEP. He's been the vice chair. He has held many positions at the IAP and also has multiple papers published in various national journals and international journals. He's been the ardent speaker and he has chaired many sessions, and we are honored and glad to have him here to chair the next session. Sir, it's yours. Sir, you're muted, sir.
Muted, Dr. Shri.
Yeah. Thank you, Dr. Krishna, for the elaborate introduction, and good morning to everyone. Special to Dr. Jagdish and my panelist is Dr. Sija. So I'm not going to spend much of time because people are waiting for her discussion. And she is a professor, Government Medical College, Tiruvandhuram right now, and has been the president of Intensive Care Chapter of Kerala and a member of Health Family Welfare Board. And her special area of interest are immunization, tropical infections, fluids and electrolytes, and where we do see fever in and out. So, and she has been author of a number of books, papers, and everything, and her contribution is difficult to sum up in brief introduction. So over to Dr. Sija.
Thank you so much, sir. Good morning, everyone. First of all, I thank the organizers for this wonderful opportunity. And definitely, it's a tall order to speak after that excellent session by Dhiren sir. So I would be keeping it simple and looking into how to approach a child with fever in the ICU. Should I share the slides or will it be shared?
Ma'am, you can. If you insist, we can share it.
Okay, no problem. I hope it's visible.
Yes, ma'am.
So coming to the topic, that is fever in ICU. We all know that is one of the symptoms that as a person working in the ICU, we will be always worried about, because prompt evaluation and treatment is important. And in an ICU, usually you're bothered when the temperature is more than 101. And more than 50% of patients, I would say in ICU, when you receive a patient, in fact, more than 70% would be having fever at one point, either at the admission or they develop subsequently. But we also need to remember that it can be either infectious or non-infectious. So what I would be really covering is what are the points that we should be taking, especially looking into when you're taking the history, what are the clinical clues that we should be bothered about, how to really order for investigations, and finally, how to go about the treatment. So before we go about the fever approach per se, we need to remember that fever happens due to exogenous pyrogens, and exogenous pyrogen can be anything ranging from an infection, a toxin, an inflammation, or a tumor, which finally stimulates an endogenous pyrogen, and then you get the hypothalamic endothelium getting stimulated and you have the fever there. So with that knowledge, that is, fever can happen due to infectious and non-infectious causes, let us see how to approach. So the first thing and foremost is every time you encounter a fever, it is important you take care of a proper history. So history means you would be looking at the fever quality. You would be looking for associated symptoms to look whether I can get a clue from where the fever is coming. I'll be also bothered about the medications the child is currently on or was prescribed before. And also, is my child having anything special risk? Is there a risk that this child can be colonized or infected with an MDR organism? Is my child special in the form that the child is immunocompromised otherwise? So that is also important when you're taking the history. When you take the history regarding fever, it's important to know whether this fever is a new onset. So if this is a fever, that is a child's fever had subsided and you're getting a new onset fever, you are thinking about a new event happening in this child. And the other side, if the fever is persistent from the time of admission, again, you need to look and see what is the trend. Is the fever increasing or fever decreasing? If it's decreasing, even if it is third or the fourth day, you should be okay. You would be also bothered about the diagnosis, as it was discussed in the morning. If it's something like a typhoid, you are not expecting the fever to come down on 2 to 3 days. You're expecting the fever to be there for a longer duration, especially because the organism is sitting in the reticuloendothelial system and will take some time to clear. So the diagnosis also decides us whether to panic, whether to investigate when the fever is persisting. And the third thing is definitely about the grade of fever. So what does the grade of fever tell us? When you have a fever, which is a low grade or a moderate grade, that is something less than 102. It can be either infectious or non-infectious. Some of the common non-infectious causes may be a deep vein thrombosis, maybe a thrombophlebitis, much more common. But when you have a high grade fever, that is something between 102 to 105, it's commonly infectious. So when you have a high grade fever, look for infection. Whatever be the etiology, the chance of infection is high. But when you have hyperpyrexia, that is fever above 105, unlikely to be infectious. So we have to think of non-infectious causes when you have a moderate grade fever or when you have hyperpyrexia. Now, why is it important to know what the child is on, or how does the medication history is relevant in a child in ICU? The medication history is relevant in the sense that we have to see that you have presumed an infection or you have confirmed an infection. Is the drug that you have selected is right? Is the dose that you've selected is right? Is it being administered in the right format to say that the drug is being effective or not? On the other side, you have to see that is these drugs, are the drug the child is currently on, making him prone to certain conditions which may run up in fever. For example, a secondary infection due to fungus, a Clostridium difficile diarrhea, or you have to also think about drug fevers and also drug withdrawal. So that is one thing, drug withdrawal. Remember, when the child is on a ventilator for a prolonged period of time, they would be on an opioid infusions. And when more than 5 days a child is on an opioid infusion, there is a chance of withdrawal symptoms, which may manifest with tremor, which may manifest with sweating, hyperventilation, and fever also. So that also needs to be kept in mind. A word about drug fever. Remember, all the drugs that we use, almost anything can cause fever, but some of the drugs are known to cause fever, have a higher incidence than others. For example, your amphotericin B, your vancomycin, penicillin, phenytoin may be prone to cause a drug fever. So diagnosis of drug fever, there is no confirmatory test. It's always a diagnosis of exclusion. If you find that your inflammatory markers or your markers of infection, like your CRP or procalcitonin is coming down, your organ functions are improving, but the fever is persisting and the child is on a particular drug for the last 7 to 10 days, which is known to cause a drug fever, this thought should cross our mind. And remember, the moment you stop the drug, it is not going to come down. It's going to take another 48 to 72 hours of withdrawal of a drug for the drug fever to subside. So that is also one thing that should come in mind. Now, from history, we move on to clinical examination. That is exactly what we do always in all patients that we come across. When it comes to the ICU, whether it is a new onset fever or it is a persisting fever, every day look at your child as if you are looking for the first time. Start from the head, end up at the toe, look at each and every organ there. Because every day you can have a new symptom or a sign coming up, which may give you important clues. So from when you go, you'll be looking at infections at the various organs in a systematic way. It's important always to look for a new onset murmur. See that whether you're having probably an infective endocarditis or a pericarditis. See that something in the abdomen are you missing? Is there a hidden abscess sitting there, maybe a liver abscess or a deep-seated abscess? Look for organ involvements, look for joint involvements, look for rash. A thorough clinical examination every day is important when it comes to ICU. But there are also certain peculiar findings that we should be specifically looking for, because we do a lot of things in ICU on a child, and those things that we are doing may be a cause of fever. So starting from the ET tube that you've put in may be a reason for a VAP. The IV lines may be causing thrombophlebitis. The central line may be responsible for a central line associated bloodstream infection. Your catheter may be responsible for a urinary tract infection. The drugs may be causing a drug fever or a drug withdrawal. The wound, a surgical wound, may be hiding an abscess between inside it unless you dress open and unless you open the dressing and see whether the abscess is there, whether the infection is there. Same applies to your central lines also. Remember, if you're putting a gauze dressing, you need to change it every 48 hours. So gauze dressing comes, for example, in a dengue, you have put a central line, you have a bleeding from the side, you try to keep it more secure, maybe with a dynaplast, you would not see whether the infection is happening there. If you have a transparent dressing, it is okay to change the dressing every 7 days, but occluded dressing needs to be changed every 48 hours because you need to look whether the infection, the source of infection is that or not. Clostridium difficile, a new onset diarrhea in a child who's already on an antibiotic for quite some time. Do think about that. Yes, you can look for the toxins in the stool, but you can simply, a screening test, maybe looking for an occult blood to see if the blood is there, maybe an indirect clue that you're dealing with a Clostridium difficile infection. Now comes the next question. Do we need to investigate all cases of fever? Anytime you find a child developing a new onset fever, do we need to jump in and evaluate? Yes, evaluation, clinical examination is mandatory. Any fever more than 101, definitely evaluate. But also keep in mind that if I'm dealing with a post-operative child, I'm expecting a fever in the first 48 hours. Only if the fever is persisting beyond 48 hours, or if you have associated features of organ dysfunction, then I would think of some other thing that has happened. Similarly, when you have a child with an intracranial hemorrhage, especially subarachnoid hemorrhages, remember, they itself can cause a fever. So if you don't have other markers of infection, you don't have to really search for it. Similarly, after a blood transfusion, you can have febrile non-hemolytic reactions happening within the 6 hours of administration of a blood or blood product. So these will be some of the conditions where I may little stand back and think whether I need to send an investigation. Evaluation, we would always be doing. Now coming to sending appropriate investigations. So as I already said, the moment you have a fever running from moderate to high, we need to evaluate. And always start from the basics. No need to jump to the high-end investigations. The more investigations that you send, the more results you get and the more confused you become. So go from the basics. I always say take the first step first, don't jump. Send for the blood routine. It gives you important clues. A child who's showing leukocytosis, probably you're dealing with a worsening or a new onset infection. A child who is worsening clinically and the counts are falling, it is a much more ominous sign. The infection has caused an immune paralysis, or you may be dealing with an HLH or something else. And similarly, a simple ESR. A child worsening with a falling ESR, again, may be a clue of a non-infective etiology there. Urine routine and urine culture, I would say don't send it routinely. Don't send it routinely, send it only when you are suspecting a urinary tract infection. Because because of the catheter there. And remember, urine is not a sterile area, and you taking a culture from the bag is completely not recommended. So if there is an indication, or if you think that the urinary source is the infection is a urinary source, then always put a new catheter and take the sample for culture. Don't take it from the bag, or take it from the catheter which is already there. Then regarding cultures from the other side, yes, whenever indicated, definitely send the blood culture. In the morning, it has been highlighted that the single most important thing that gives you a positive blood culture is the amount of blood that you're taking. So even for a preterm, you need to take at least 2 ml. For a child, you have to take at least 5 ml. So when you're taking a pediatric culture bottle, the minimum sample is 5 ml, and an adult culture bottle, the minimum sample or the maximum sample is 10 ml. So blood broth ratio has to be maintained. Too much of the blood will also harm. Too little of the blood will also not give you a yield. You're doing a BAL, never forget to send a culture. You're doing a bone marrow, never forget to send a culture. And pus, if it is there, can also be sent for cultures. Then, of course, the cultures take a longer time, turnaround time, even though now you have modern methods by which the moment you get a signal, you're able to identify an organism, you're able to identify the resistant gene which is present, which helps you guide your treatment. But before the culture becomes positive, you can always look at the biomarkers. And also remember that these biomarkers are not specific for infection. CRP will rise late after 24 hours. It peaks by 48 hours. On a day-to-day basis, it might not help you, but might help you in trending. Procalcitonin rises very fast and falls also fast when you're giving an appropriate antibiotic. But remember, both CRP and procalcitonin can be positive in non-infectious causes also. So always your clinical clues, your clinical examination, along with that, you combine your investigations and never investigations alone. Then we're suspecting fungal infection, some of the most difficult to grow and get a culture and sensitivity, even though not much validated, but definitely you can think of sending for a BDG or a galactomannan when you're thinking about a fungal infections. And of course, most importantly is the imaging. And I think, as I already stressed, that the ultrasound at the bedside gives you important clues for the site of infection. So now what we are discussing was we were looking for infective causes. We are sending cultures, we are sending routines, we are sending for antigens, we're looking for infective causes. But in ICU, remember, it's not always infection. A vast majority, not majority, but an important chunk are also non-infectious. So when would you think that your child is possibly having a non-infectious cause? You would think it is probably non-infectious if my child is having very high fever, more than 105. If my child is having a high ESR more than 100, yes, it can be due to infections. But very high ESR more than 100 do rule out a collagen vascular disease, do rule out a malignancy. In a falling ESR, in a worsening child, should ring a bell. Probably you're dealing with something else. Similarly, a eosinophil count that is increasing, again, think of something non-infectious. So non-infectious, commonly autoimmune, HLH, malignancy are the ones that we commonly encounter in a pediatric ICU. Coming to the treatment per se, you have two options. That is, you have to treat the cause. If you're able to find the cause, definitely treat the cause. And also treat the effect, that is, treat the fever. So regarding the treatment of a cause, before you jump into why your child is running fever, look at all the things that you have put into the baby. See that if any of that can be removed, remove them as soon as possible. An NG is there, you've extubated the child, you started oral feeds, remove it. You have a urinary catheter, you're no more on sedatives, you're no more on opioids, please remove it, let him boil off his own. You have a central line, you've acquired a peripheral line, child is off inotropes, remove it. Don't let it be there, because these are important causes of persisting fever or new onset fever. So the moment your need of these invasive lines and tubes are over, remove it as fast as possible, because that alone may be a solution for a fever that your child is running. But there are certain situations where you need to start an empiric antibiotic in a child, even though you don't know the diagnosis. That is, if your child is having neutropenia, if your child has invasive devices inside, like a ventricular assist device, or the child is on an EVD, or a child has a new onset shock. These are conditions where you would not, before the evaluation or investigation results are available, you would start them on an empiric chemotherapeutic agent, which need not be always an antibiotic. It can also be an antifungal if your clinical suspicion is high. Because in a critically ill child with an organ dysfunction, every minute counts. The moment you've decided to change an antibiotic, do it as early as possible. Ensure that the first dose is administered even before you're moving on to the next patient. Then regarding treatment of fever, that is, you're treating the symptom. Do we need to treat fever or do we not need to treat fever? So that is a little controversial question, but the one thing is very clear. Any patient with a neurological injury, whether it is an encephalitis, meningitis, a trauma, a tumor, a raised ICP, post-cardiac arrest, fever can be deleterious. So anyone with a neurological injury, treat fever aggressively. In case of sepsis, antibiotics do not decrease mortality, that we all know. The cause has to be treated. But any fever more than 40 degrees centigrade should be treated as associated with increased mortality. That means hyperpyrexia due to any cause needs to be treated, because hyperpyrexia is definitely deleterious. Which drug? However high the fever is, stick on to your age-old acetaminophen or paracetamol. And remember, enteral route is preferable to the IV route. IV paracetamol may be associated with a fall in BP of 20%. When you have hyperpyrexia, antipyretics alone is not enough. You will have to go for physical measures like physically cooling the child, keeping the fan on, giving IV fluids that are cold, or giving a GI wash or a bladder wash. All that is important when you deal with hyperpyrexia. So with that background, that exactly is the crux of the talk that we discussed till now, that is how to approach a child and evaluate and manage. Let us see a few cases and how you would go about it. These are not necessarily new onset fever. This may be a fever which is persisting or which is worsening also. So there's a 12-year-old child who's admitted with fever, breathlessness, and back pain to a local hospital. And because of the back pain and the breathlessness, both imaging of a chest X-ray as well as a CT was taken, and the chest X-ray showed bilateral infiltrative, bilateral opacity, and CT was showing some evidence of sacroiliitis, and an empiric that he is going in for a bad pneumonia. The referring diagnosis was early ARDS, and the child was started on ceftriaxone and vancomycin, and after the first dose of antibiotic and 24 hours of initial treatment, the child was referred. And post-reference, the child, in fact, when you receive the child's distress has increased, you have receiving the child on NIV. And on examination, when you do the head-to-foot examination, apart from the chest, you also find that the abdomen was distended. He was still complaining of the back pain. So you have repeated an imaging. Again, you did not find anything there. And you've sent a blood culture. You continued with the antibiotic. 48 hours later, you get the blood culture. It says that it is methicillin-sensitive Staphylococcus aureus. And so vancomycin is changed and gone for a clox with amikacin for a synergistic action. And now 48 hours after you have changed your antibiotic, you find that the child has progressively worsened. The child who had come to you with a respiratory problem is now on the ventilator, is on multiple inotropes, and is still running high spiking fevers. Now, what are your concerns? So you have a child, you have a focus of infection, you have done and you have started the ideal antibiotic, but the child continues to run fever. Continues to run fever was okay, but the child is worsening in front of your eyes. What do? Yes, the first thing is go for a clinical examination, again head to foot. Specifically look in the heart, see whether you are having any new onset murmurs. We could not pick up any new onset murmurs. The abdominal distension was still persisting there. You go for the investigations, you find that the blood routine, the counts are increasing, the CRP is increasing. Ultrasound abdomen did not pick up anything because the window was poor. There was gaseous distension also. You do an echo, which was within normal limits. You didn't find anything. You again, but in the chest, you find that there are some, you can see that some necrotic lesions, almost like bulle you are able to see. So the lung is showing that there are some breaking down lesions happening inside the lung. Apart from that, you're not getting a pleural effusion, you're not getting an empyema there. But the only clinical clue that you got was still again that abdominal investigation. So you went ahead and did a third imaging. And this third imaging picked up a psoas abscess. Remember, the interval between the two imaging is just 72 hours, and you have a psoas abscess sitting there 15x5. And immediately the child was taken up for a minimally invasive surgery. Emergency surgery was, drainage was done. And the child showed dramatic improvement after that, with decrease in fever, with You could come off inotropes in the next 48 hours. In fact, you could even extubate the child. So what did we learn from this? We learned from this that however sensitive antibiotic you are giving, if you have identified a source, if you have not done a source reduction, your antibiotic is not going to be effective. So always be in search of the source, find the source, do a source reduction as early as possible. Now, why was it that we were so persistent? We are going again and again imaging. That was because one of the images that the child had come with this X-ray, that is bilateral infiltrative X-ray, which was showing like an infiltrative pneumonia, going in for an early ARDS, subsequently went in for ARDS. But the imaging, the CT abdomen that was taken to look for for the bony injury for which he was complaining the pain, in fact had picked up these small nodular lesions in the lung, which was evidence of a septic emboli in the lung. So whenever you encounter a septic emboli in the lung, remember the source of infection is usually intra-abdominal. So that is, you are having an infection in the abdomen, which through the vein is reaching your lung and causing that seeding in the lung. So there's multiple times I've come across, and usually when you have these septic emboli, they finally go for a very bad lung. In fact, for this child, the whole of the lung was replaced by a huge bullae, but we waited for 3 months and he recovered completely. So the learning point here is do the source reduction, and when in doubt, never hesitate to do a repeat imaging in search of the source. Now coming to the next case. It's a 4-month-old child who had a single dysplastic kidney, now admitted with an E. coli positive urinary tract infection, which was sensitive to piperacillin tazobactam. The child was started on that. Being a small baby, the child was in the ICU, and in the next 48 hours, the fever decreased. But after 48 hours of subsidence of fever, the child developed respiratory distress following a feed, for which a GERD was suspected, and the child was started on domperidone with lansoprazole. 2 days after this, the child had new onset fever, this time fever going up to 106 degrees, and following which you again did a complete evaluation. You did a chest X-ray also. You find there was nothing wrong in the X-ray, even though we had initially suspected that aspiration. The chest was clear. The CVS was within normal limits. Per abdomen also, we could not find anything new. And you did a repeat counts, which was showing leukocytosis. The platelets were going up to 4 lakhs. Still no clinical clues why the child was running such a high fever. You again come back to the child and you realize that this child is looking different from what the child you had received. Now the child was irritable. Child was showing some rigidity and tremor of both lower limbs and upper limbs. And also the child was having sweating. So this is not an opioid withdrawal. The child was never intubated or ventilated. So what was going wrong with your child? So you went ahead and did the organ functions again. You find that OTPT has gone up. And to your surprise, the urea has gone up to 133. Calcium has fallen to 4.6. And CPK has gone up to 2,766. So what are you dealing with here? So you are dealing with a baby who's showing some features of rigidity, irritability, and a high CPK count. So basically, you're dealing with a neuroleptic malignant syndrome secondary to domperidone. So here, the domperidone was stopped. The child was hydrated well. Child was calm with lorazepam. And because of the high CPK, alkalinization was started and bromocriptine was also given. And finally, the child improved. So what are the learning points from this child? Hyperpyrexia above 105 associated especially with neurological symptoms. Think of non-infective causes. Rigidity and hyporeflexia, it may be a neuroleptic malignant syndrome. Hypertonia with clonus, it may be a serotonin syndrome, especially when you have GI symptoms associated with it. When a child during surgery or a post-surgery lands up having hypercarbia with hyperkalemia, think of malignant hyperthermia. All these conditions are usually associated with an increase in CPK, and usually it has to be managed with a physical cooling, giving of benzodiazepine. In serotonin syndrome, ciproheptadine is given. In NMS, bromocriptine is prescribed, and in malignant hyperthermia, dandrolene is prescribed. And dandrolene is a muscle relaxant. It can be given for neuroleptic malignant syndrome also, but in our child, we had just taken care with the lorazepam as well as bromocriptine. So now coming to the next case. 12-year-old girl child was admitted with fever and cough of 3 weeks duration. The child was initially admitted to the ward. And tuberculosis was suspected because of the long duration of cough. Your CB-NAT was done, it was negative. Investigations were showing anemia with a polymorphic predominant count with slightly lower side platelet of 1.7 with hypoalbuminemia and hyponatremia. CRP was only 1. The child was initially started on cefuroxime with doxycycline, and then as the fever persisted and was increasing, it was changed to Piptas, Vanco, and oseltamivir. None of the cultures were positive. NP swab was also negative. Meanwhile, the respiratory distress worsened. The fever was increasing and the child developed new onset shock. And that is the reason why the child got shifted to your ICU. Clinical examination was unremarkable except for the hypoxia, the respiratory distress, and the shock. You did not find a lymphadenopathy. You did not find a pneumoma. You did not find anything, any rash to really pick up something. Blood routine was repeated. It was showing that the counts were falling. Cultures till then had not gone down, had not received anything, any positive one. Since the ESR was high, you did a bone marrow, which came as normal. You also sent for some of the inflammatory markers, the ferritin, because of the falling count. Probably a thought of HLH came and the ferritin was sent, which was high, but a ferritin more than 2000, it is just sensitive. You cannot say it is specific. A ferritin more than 10,000, you may think of infection-associated HLH. But an ESR of 120 almost rules out an HLH, because you think of HLH when the counts are falling and the ESR is also falling. When the ESR is rising, that means your fibrinogen is going up, unlikely to be an HLH. So now you again went for the imaging. You did an echo, you picked up a coronary dilatation. So are you dealing with an MIC? Unlikely. Such a long course. Pericardial effusion was there, which made you think, are you dealing with a vasculitis? Because you're having such a high fever and a high ESR also. CT angio revealed beaded appearance of the celiac artery as well as the mesenteric artery. And finally, your serology and MRI for brain were also showing abnormal findings. And the final diagnosis, in fact, was SLE in a child with multifocal involvement. That is, you had a lung involvement, you had a cardiac involvement, you also had a CNS involvement. So what did we learn from this case? We learned from this case that repeatedly evaluate the child when in doubt. When you have a falling count with a high ESR, it rules out an HLH, but definitely think about a collagen vascular disease. A malignancy should also be in back of your mind. An ESR more than 100, collagen vascular disease and malignancy should be considered. And when you have the CRP ESR discord, think of SLE. In all other collagen vascular diseases, usually there is no discord. So when you have a CRP low and a high ESR in a suspected collagen vascular disease, definitely think about SLE. Now coming to the last case, that is a child presenting to your ICU with fever with thrombocytopenia. Penultimate case, a 4-year-old child coming to you with fever, lethargy, and generalized flushing. Investigation done at the local hospital showed leukopenia with lymphocytic predominance and thrombocytopenia. So suspecting a dengue, the child was referred. But when you examine the child, you realize that there was a small ulcer in the calf. The child was having, in fact, bounding pulse with a tachycardia. Your systolic BP was 90, but your diastolic BP was sitting at 10. So you are definitely not looking at dengue, because in dengue, you're always expecting a narrow pulse pressure, unless you're telling it is a dengue encephalitis, or you're telling that there is a co-infection, or you're telling that there is a liver failure. Otherwise, you're expecting a narrow pulse pressure. In dengue, you're not expecting an ESR of 110. Any child in shock who has an ESR more than 30, isolated dengue infection is out. You can have a co-infection, but you cannot have an isolated dengue infection, because dengue causes hemoconcentration, dengue causes rise in PCV, dengue is associated with a low ESR. So basically here you are dealing with a child with septic shock. So you are having a child with a febrile neutropenia. So whenever you have a child with a fever, with a low count, with a low neutrophils, you have to cover for, and presenting to you in shock, definitely you have to cover for Pseudomonas and also cover for Staphylococci. So the child was started on piperacillin tazobactam with vancomycin. But by day 3, the child's general condition had worsened. The fever was increasing. Again, the child who had come to you in a compensated shock has now gone for a decompensated shock on multiple inotropes, and her organs are also failing. So now the diagnosis, what is the reason? Why is the child not improving, or why is the child worsening? Is it because of some organism which you have not covered? Or is it because the antibiotic that you've used is probably the organism is resistant to it? Is because we know that nowadays piperacillin tazobactam resistance is very high, close to 60% as for Klebsiella infections according to the ICMR data. So probably your antibiotic selection is wrong. Or is there a source which we need to reduce? You again search, you could not find a source. Fungal. Children with neutropenia, definitely we think of fungal. But a child who does not have a previous episode of immunodeficiency, who does not give you, who was otherwise healthy, for whom you have not found any risk factors before, developing a fungal infection as early as 3rd day of admission is in fact unlikely. So what are the reasons, or when are the conditions where you think of fungal infections in ICU? You should think of fungal infections in ICU because it is the 3rd most common cause of healthcare associated bloodstream infections. And it is the 2nd most common cause of central catheter associated bloodstream infection. So any child you have put a central venous line, or any child who's been in your ICU for some time, any child who's immunodeficient, think of fungal infections. Remember, the mortality can be as high as 50 to 80%. And in India, 80% of fungal infections are due to Candida non-albicans. As I already said, think of fungal infections and immunodeficiency, neutropenia, prematurity. One of the important causes, preterm babies, they have been taken care of in the NICU, they've received multiple antibiotics, they land up in the PICU 1 month later. Think of fungal infections sometimes upfront. Organ transplant recipients, think about it. In other normal children, think about fungal infections when the child is already on antibiotic for more than 5 days, when there is a central line catheter, when the patient is on TPN, it may be a amino acid infusion, it may be your lipid infusion, all of them increases the risk for fungal infections. Don't forget about laparotomy, acute pancreatitis, it can, and anything, anastomotic leak, because GI is one area where the Candida can get colonized and can enter your circulation. So think about fungal infection in any sick child. But our child definitely had one risk factor of that neutropenia, but was too early to really consider a fungal infection at this point. And blood culture this time showed Pseudomonas sensitive to piperacillin tazobactam. So where did you go wrong? You are giving a sensitive antibiotic. You have done a complete thorough clinical examination. You find that the child is sinking and organs are failing, but there is nothing that you can find as a source and you want to reduce. So what would you like to do? So where are you going wrong? Remember, when it comes to Pseudomonas, looking for the newer non-enzyme, your newer gene studies, that is, if you get a Pseudomonas, you get an organism, you can look for the CARBA-R, you can see whether it is sensitive or resistant and change your antibiotic according to that. Remember, as far as Pseudomonas is considered, even when the gene studies tells you that CARBA-R is it is not present, that is, it is sensitive to meropenem, your organism may be resistant to meropenem. That is because Pseudomonas is one of the organisms that has the intrinsic capacity to acquire resistance after exposure to a beta-lactam. So don't blame your microbiology lab for giving you the diagnosis that Pseudomonas is sensitive to piptaz and the child is not responding to piptaz. Understand that Pseudomonas is an organism, very clever. It can acquire resistance after it is exposed to a beta-lactam antibiotic. And remember that it has many different methods of acquiring resistance. It can cause upregulation of the efflux pump. It can cause change in cell wall. It has differential sensitivity. That means you will find that a lower grade antibiotic may be sensitive, where a higher grade antibiotic may be resistant. So keeping all this in mind, you have to deal with a Pseudomonas infection. So these are one of the rare conditions where you may think of using a combination antibiotic so that again a resistance does not appear. And you will also think of optimizing your pharmacokinetics and pharmacodynamics by, whenever feasible, giving a loading dose initially followed by your maintenance doses, giving or antibiotics which are time-dependent killing as an infusion over 3 hours or even over 24 hours, and concentration-dependent antibiotics as a single OD dose. So all these are important when it comes to organisms like Pseudomonas. So what happened to our child? For our child, The bone marrow was done because we didn't have a diagnosis. We didn't have the cause for that so much low count, but bone marrow, we could not find anything abnormal. The child, in fact, changed to upgradation of antibiotic to meropenem and amikacin and was subsequently discharged office after a slightly prolonged hospital stay. But unfortunately, 3 months later, the child presented with generalized lymphadenopathy, and this time the bone marrow revealed that the child was having acute leukemia. Now, we do not know why the bone marrow initially came as negative. Was it a problem, and was it because many times one of the common wrong practices that you come across is that when you find a child with high fever, there is a practice, at least in some part of country, to give a steroid along with it. Remember, as far as malignancy is considered, even a single dose of steroid can mask or can take away the findings in the bone marrow. And it's also important to remember that whenever you come across a child with Pseudomonas infection, it is unlikely that it is a normal child. Always work up for immunodeficiency, always work up for some other underlying disease, because community-acquired Pseudomonas infections are rare. So the learning pearls in this case is dengue leukopenia is associated with low ESR and a high PCV. ESR more than 30 in shock rules out dengue. Sensitive organisms can acquire resistance in vivo, so don't blame your labs. Pseudomonas is an unusual organism to cause community-acquired infection. Always rule out immunodeficiency. So the final take-home message, I just have one message. Look for what is there and not what you want to be there. Don't assume your diagnosis. Don't assume your investigations. Look again and again. You will find something. You keep your differential diagnosis as wide as possible. You will pick up something and you will see the truth. Thank you.
Thank you, Dr. Sija. And rightly, over a very short time, you have nicely brought out that when we are working in ICU setting, one need to keep your eyes open. It's not every time going to the bacterial infections. And rightly, we are those who we are working in ICU setting, we should be aware that now, if you look into the data, hospital-acquired infections are more common in our setup as compared to the Western. And every time we should not be carried away by the Western data. We should try to look into. And your cases were very highly educative, and they give. I just want to add on just one brief comments that for when we are doing this ultra module, we do not advocate more than 1 ml of blood in case of both preterm and infants, because we know that there the organism concentration is very high. So you need not to go even for 2 ml. And rightly you said that one more learning point is that when you're suspecting HLH, there's a very sudden drop in ESR. So one need to keep it. Whether your ESR is going up and CRP is going down, then you have to think of SLE, and the reverse is true for HLH. These are very important two clues when you are monitoring these patients. And no doubt, there is no substitute for clinical examination. And for ICU patients, most of the time, we are just carried away by the lab investigation. So I think then patient is not improving and is developing high-grade fever or deteriorating. Then rightly you pointed out in the case number 2 that there is no substitute for clinical examination. With this, over to organizers. It's really a very well thought and very good presentation.
Thank you, sir. Thank you for hosting the session, and thank you, Shija ma'am, for the wonderful presentation there. Thank you very much. Any questions from the panel? Any question from the faculty who are joined in?
Thank you, Dr. Shija. It was a fantastic presentation with all very good learning points for all of us, including the PGs. One comment I had on that was for your last case. There are current recommendations that if you find a child who comes to you in septic shock and you're suspecting, then the coverage should be with 2 anti-pseudomonal or gram-negative antibiotics. That is, either you can use piperacillin, tazobactam, meropenem, or even cefepime for that matter, along with the aminoglycoside. So what are your comments on that? Because the current recommendation is to use vancomycin plus this combination of 2 antibiotics to cover for the gram-negative.
Yes, I totally agree with you. This is an old case. I totally agree with you, because nowadays the resistance is also definitely high. And the recommendation for immunosuppressed person with a neutropenia and in shock, it's always better to cover.
Thank you, ma'am. Thank you.
Jagdish, I am muted, sir.
Yeah, no, I finished. Thank you.
Yeah, thank you, sir. Thank you very much. Anand Keshavan, sir, on Vasu, sir. Any questions, or can we move it, sir, to the next session?
Right. Very well explained. I think we can go on to the next session.
Yeah. We thank you very much, Sita ma'am. Thank you, Ashwini Sood, sir. Thank you very much. We move on to the next session, and that is one of the important or the show-stopping event, which is the CPCs, which has got lots of interest from all the audience. We look forward for the next session. To chair the session, to introduce the panel and things, we have Dr. Soumya. Dr. Soumya, it's over to you.
Thank you, Dr.
Can we have
Krishna, for
SBS
the
slide,
opportunity.
please?
It's an
Stuti?
honor to introduce SBS sir. I think sir needs no introduction in pediatric circles. He's the doyen of the infectious diseases. Can we have this?
Stuti, can we have the next slide, please? Dr. S. Balasubramanian sir's slide.
Sir needs no introduction, as I was rightly pointing. Sir has been at the helm of the lot of training programs for infectious diseases and pediatrics. Sir has been the associated with the Kanchi Kamakoti Child Trust Hospital in Chennai, where Sir has been the former medical director. Sir has been the trustee on the Child's Trust Medical Research Institution. Sir has been the former professor of pediatrics in SRMC Chennai. Sir has served on various advisory and been at the helm of various teaching programs across many programs of IAP. And Sir has lot of publications, over 150 index publications in pediatric infectious diseases, and over 40 orations, and over 500 sessions in IAP forums and PG teaching programs. Sir also is the fellowship coordinator for the Infectious Diseases Fellowship at Kanchi Kamakoti Trust Child Trust Hospital in Chennai. And sir, over to you for taking ahead the next session on CPC, sir. Thank you.
Thank you, Dr. Soumya. We are going to have a session on clinico-pathological conference, and I guess the session is going to be carried out by Dr. Archana. Am I right? Yeah, Archana.
Yes.
Yeah, welcome, Dr.
Yes, sir.
I'm very, very happy that she's doing it because she's a fellow of the IAP PID group, and she's currently the consultant in pediatric infectious disease at the Manipal Hospital, Bangalore. She was one of the earliest fellows in infectious disease from IAP. She had also obtained the PG diploma in Oxford. She is trained in infection control and prevention. Her areas of interest obviously are infectious diseases, particularly tuberculosis, infection prevention and control. And she has presented multiple papers, including papers in ESPAD, WSPAD, etc. She's a regular faculty in our PID conferences, and I'm sure she will have a fantastic session. Over to Dr. Archana. Thank you very much.
Thanks a lot, sir. Shall I share the slide over here?
Yeah, Archana ma'am, also we have two more discussions with us, along with we have Dr. Vikramesh Kumar joining in today and Dr. Mahesh Koresa joining in. Can we have the slides, please? Yeah, Dr. Vikram sir is a professor from the Subbaiah Institute of Medical Sciences. He is a consultant pediatric journalist from Shumoga. He has been the speaker in many national and international forums. Vikram sir, welcome sir. Thank you for joining in. Also, we have Dr. Mahesh Kore from Sri Hospital Pediatric and Neonatal Center from Nipani. He's been on various IAP activities. He's been ardent speaker in various national and international forums. Thank you, sir. Thank you for joining in. Thank you, Mahesh sir. Archana madam, it's over to you.
Yeah, sure. Thank you. I'll share the slides. Are my slides visible?
Make it full screen. Make it full screen. Yeah. Yeah, that's fine.
Yeah. Okay, sir. First of all, I would like to thank the scientific community for having given me this opportunity to present the CPC protocol, especially in a session which has been chaired by SBS sir. I'm really happy to be in this session. Thanks for the opportunity. So, and I'm also really happy that I'll be discussing this case in front of two senior pediatricians, Dr. Vikram and Dr. Mahesh Kore. So let us hear the valuable inputs from our the senior professors over here. And so let me get into the case. Yeah. So this 8-month-old baby girl who was adopted by Children's Home at Bengaluru, where she was found abandoned with animal bite marks over the ears and fingers in the garbage. She was apparently normal till this episode. She was brought to the emergency with swelling in front of the left ear since 1 week, not increasing in size. And she also had difficulty in feeding and drooling of saliva since 1 week. This was associated with deviation of the mouth to right side and drooling of saliva through the left side of the mouth. She also had fever of 4 days, which was 4 days back, which was there for 2 days. Again, it had recurred since 1 day. It was insidious in onset, moderate grade, intermittent, not associated with any rigors. She was afebrile for 2 days. Then the fever again started since 1 day. So also she had reduced activity and she was drowsy since the past 1 day. And the child was treated on OPD basis in a peripheral hospital with oral antibiotics and oral steroids in view of suspected Bell's palsy. And there was no history of any seizures or vomiting, no history of cough, cold, stridor, or rashes. So this is our presenting history. So if any other relevant history is required, please you can go ahead. And what other possibilities, what are the etiologies you can consider with the initial history?
Can you go back to the first slide?
Yeah.
Yeah. This was an adopted child. Okay. And that was an animal bites marks were there, right? At that time or this time?
Right at the time of adoption. So when the child was
right.
abandoned, the bite marks was there. Around the child was abandoned around I think 2 to 3 weeks prior to the hospital admission.
Okay. And the child is ill since last one week, no?
1 week, correct, sir.
And started with the swelling in front of the left ear.
Yeah.
Without any fever.
No, without any fever. The fever was there only from 4 days.
Yeah. Starting with the swelling, which was probably not infective initially, or there was no inflammation as such, or there may be a mild inflammation which was not noticed because it is a abandoned child taken care by the other system. Okay, and there was a feeding difficulty and drooling of saliva since 1 week, and associated with deviation of mouth to the right and drooling of saliva. Maybe it is associated with the Bell's palsy, whatever they are thought, because there was a deviation, or maybe there is something in a posterior pharyngeal or something like retropharyngeal area, which is causing difficulty in swallowing and drooling as well. But at this point of time, there was no fever. So it was gradually increasing probably. And then he started having fever. That baby has started having fever. Maybe now the episode or their size has increased and baby has started fever. And drowsiness also says that maybe he was hypoxic. Maybe there are so many causes of drowsiness in a febrile child with swelling. So my thought is it is localized to the left ear and to the retropharyngeal space at present, because you're not mentioned about stridor or breathlessness at this point of time.
Yes.
Or to Vikram.
Yeah, so thanks to the organizers and namaste Subramaniam sir and namaste Kore sir. And thanks so much, Dr. Archana. So when the child was brought to the adoption center, with these bites, was the child given any prophylactic injections?
Yes, sir. So the child was being, actually, when we had inquired, they said that the child was given for both rabies and for the tetanus prophylaxis was given.
So basically, looking at this, looks like um, an acute and a progressive infectious inflammation probably we are dealing with. Started off probably looking at this as the swelling in the left front of the left ear would be probably, if you go with the anatomy, probably parotid of lymph node or probably the parotid enlargement, along with involvement of the facial nerve. And looking at it, it could be an infectious process that is progressing. So the child has already received rabies and probably rabies immunoglobulins or monoclonal antibodies, right?
Actually, we don't have the details of it, but they say that they have given a costly medication, which we don't.
Okay.
I'm not sure about whether it was immunoglobulin or monoclonal antibodies. So, but they say that that was given along with the vaccinations.
So, in a matter of 24 hours after the fever began, fever went on for 4 days, and after 4th day, the child had reduced activity or drowsiness, probably developed or the infection progressed to the encephalon.
Most probably, sir. We don't know exactly where is the localization of this the facial palsy. Whether it is towards the thing, I think on examination we can further progress with that. But with the history, this is only we could get the history of drooling of saliva, and there was some deviation of the mouth. That's it. And otherwise, the child's sensorium drowsiness was there, but there was no other loss of movement of the limbs or anything. So there was no particular localizing features other than these. So could have been even a central cause, or it could be a peripheral cause of facial nerve. So not sure. But initially, the child was fine, and later the drowsiness has started only from past 1 day.
Yeah. So since 24 hours, the child has become drowsy. So the infection is progressing, or rather, the inflammation is progressing. And before they came to you, what were the medications and what was the treatment given? Apart from
the child was on some oral antibiotics. The child was on augmentin and also was on oral steroids in view of probable Bell's palsy. So actually the duration should have been for 3 days.
Yeah, looking at it, I mean, with an obvious deviation to right side, I would put it more into an LMN lesion rather than a Neumann lesion here. Probably things have started locally and things are
seems to be so, yes, sir.
Yeah. So let's see, I mean, how it unfolds.
Yeah. So to add on, so what was our thought process? Same as being pointed out by the discussant. So we did think about rabies also when inquired. The child actually falls under category 3 bites, so and hence even the immunoglobulin, probably the immunoglobulin along with the vaccination was given. And also this child fits in with, we did not know even the vaccination status of this child. So obviously, so and hence the tetanus immunoglobulin also would have been important, but we did not know that whether the child had received the tetanus immunoglobulin, but obviously the child had received the vaccination for tetanus. And with the animal bites and even tick bites also was considered with the Bell's palsy. Or we did consider in terms of human lives, but we are not endemic city with Lyme's because this child was abandoned in Bangalore. So probability is less likely. And also we did consider about these particular organisms, which can be caused by different bites, and that causing a lymph node or a parotid infection, later causing a facial nerve palsy, as already told, like a element sort of palsy also was being considered. So now coming to the general physical examination of this child, baby was drowsy but arousable, and the vitals, heart rate was 120, BP 100/70, and respiratory rate was 36, and saturation was 98% in room air with a normal temperature, and the capillary refill time was less than 3 seconds. So by large, the vitals were stable, and there was no other And the anthropometric measurements, if we see, the child was well-grown child. The weight was in the 50th to 95th centile, with the length in the 15th to 50th centile. So the head-to-toe examination had shown no facial dysmorphism. There was some nibble left ear and fingers with scarring, which was present. And there was also a nodular swelling, which was present in the left parotid region of the size of 1 by 1 centimeter, which was firm in consistency, mobile, not fluctuating. There was no local rise of temperature, and the skin over the swelling was normal. And so the central nervous system examination, the baby was drowsy but arousable. There was a deviation of the angle of the mouth to the right side, drooling of the saliva from the left side of the mouth. Also, there was a loss of the nasolabial fold on the left side. Signs of seventh nerve palsy was there. And there was also nasal regurgitation present, and there was an absent gag reflex. The other cranial nerve examination was normal. The bulk, tone, and power of the child was normal. Deep tendon reflexes couldn't be elicited, and there was no cerebellar signs. And other systemic examination was normal. On day 1, this child was initially monitored in the PICU, and she was managed with IV fluids and antibiotics, ceftriaxone, and even acyclovir was being initiated, and certain supportive measures were given. She was clinically stable. And this was the day 1 investigations. The child had, in the CBC, we can see there was a leukocytosis with normal neutrophil and lymphocyte distribution, and there was a thrombocytosis, and the CRP was negative on day 1. And the serum electrolytes by and large were normal, and the creatinine was normal, but the plasma glucose was on the lower side, 45, and blood culture was sent. Also, we had done an ultrasonography of the neck initially, which had shown a prominent intraparotid node, and the parotid gland was normal, but most probably the swelling was attributed to the lymph node, which was around 9 by 6 centimeter, which was a hypoechoic nodule. And by day 2, the child further deteriorated, had a further depressed sensorium with pooling of secretions, and the compromising of the airway was present. So the child was intubated in the PICU and was started on mechanical ventilator support. The antibiotic was escalated to meropenem and vancomycin with the clinical deterioration. It was started on neuroprotective measures and also prophylactic anticonvulsants. So what are the possibilities now? What investigations can we consider? What would be the rationale for ordering each of these investigations? Any opinion on the antibiotics which we have started initially and later on? If not, what other antibiotics can be added, or any other antimicrobials to be added? Over to you, please. Yeah.
Vikram sir, please. Hello. Am I audible?
Yeah, you're audible, sir.
Yeah, go back to your first slide again, where we have started on examination.
First slide, yeah. Okay.
Yeah.
The font size is quite small, so it becomes difficult for us to see.
Yeah. And what is one more point we got is that here the baby has nasal regurgitation. That means the glossopharyngeal nerve is already involved. Okay, so it is not a lower motor type of seventh nerve palsy. Probably it is a upper motor, and ninth nerve is involved. And or if it is lower motor type of seventh nerve palsy, so ninth is also involved. It is a disseminated then. Okay, so area of localization comes as the child is drowsy, seventh nerve, nasal regurgitation. Maybe we are dealing with the pons area and probably a medulla also. Okay, nothing, but his head circumference is normal up till now.
Sir.
As
the anthropometry is normal.
Yeah, that says that we are not dealing. This is acute infection. He doesn't have any previous subtle, or because it was a abandoned child. That's why I'm worried about that. Head circumference gives me a clue that it is acute now, and we are dealing with that. So that parotid node which was there, and there was a bite mark. So we want to find out what that, maybe small bite marks are there, then it is not a dog. Maybe we are dealing with a cat and rat or something like this. And we have to think of that unusual organism which can cause this type of disease, a disseminated, and to that of parotid lymph node also involved. So I am thinking of other organisms which can cause this type of illness, and they are not responsible for penicillin or penicillin ring-like structures having antibiotic.
Okay, sir. So Vikram, sir, from your side, any additional points, sir?
Yeah, I just wanted to know if there were any rashes on the baby at the time of admission anywhere.
No, sir, no rashes. No rashes
anywhere.
Except for the nibbled marks over the ear and this thing. There was some scarring, that's it.
So if there were nibbled marks on the fingertips, are unlikely to be just a cat bite, probably a rodent bite.
Or rodent, yeah, right.
Very likely.
Small.
Yeah. So, and then were there lymph nodes anywhere else?
No, sir. No other lymph node was palpable except for the
node.
cervical and the parotid.
Okay, so I would put it as, I mean, if you look at the amount of paralysis there, I would put it as more of a local element type of palsy, facial nerve, and also involving the peripheral nerve supplying the oropharynx, because if you have UMN, you wouldn't really have nasal regurgitation. So here the child has nasal regurgitation with absent gag. So the palsy is...
was involved.
Hello?
Hello. The baby has a element of 7th nerve palsy, and probably the lower motor type of gag replace was nasal. There was a regurgitation that says that 9th nerve is also.
Yeah, so something is happening locally, and there is local spread towards the CNS that is happening.
Yeah.
And probably I would definitely consider, and I just wanted to know what was your thought process when you started off with the initial empiric group of antibiotics here. You started off with, what was the antibiotic chosen there? Ceftriaxone. So you started off with the 3rd generation cephalosporin with an aminoglycoside, right?
No, sir. One is ceftriaxone was started initially.
Okay.
So initially the child was started on ceftriaxone and acyclovir also. So because there was some drowsiness, so even that also was initiated.
So what was the thinking there when ceftriaxone was started? Because the child landed up with...
Yes, sir. So there was facial nerve involvement along with the altered sensorium. There was a drowsiness which was there along with the nasopharyngeal regurgitation which was there. So obviously even upper motor neuron was also considered in this child. So other than element. So hence we thought to cover for the meningoencephalitis, we just gave the cover with ceftriaxone and acyclovir. So that was the thing. So there was a local infection which is spreading and causing the most probably upper motor neuron involvement also was considered. Because this was started along with the examination findings, right? Because we saw that there was a 9th and 10th most probably involvement. So considering that, we thought it could be even a UMN involvement also. So even we were not clear about the UMN is this thing, but we thought better to cover even for that, and later might be de-escalate if not required.
No, and how did the child present with nasal regurgitation? Because if the child was drowsy and probably
there was drooling of the secretion, sir, and the child was not able to swallow anything orally.
Yeah, that's what. So probably when the child was drowsy and in ICU, the child must have been nil by oral, right? So in what way did the child present with nasal regurgitation? Was something given through the mouth so that you could find the child regurgitating through nose, or?
Actually, it was tested initially, sir, but so otherwise there was actually the child was initially on the day 1, the child was not get nilpal orally. It was on the second day. Second day only the child went in for the intubation.
Yeah, because if it's forthcoming that there was nasal regurgitation, then things point more towards element kind of local kind of thing that is just passing from there to the midbrain, brainstem rather.
Brainstem.
So,
madam, immunization status was not known of this child.
Yes, sir. So we did not know.
Maybe we are dealing with some toxin like. Okay.
Yeah. So I also would like to think about all the things that you have put in your differential diagnosis, focusing more on probably a rodent bite associated with an acute infectious process that has begun here, or rather is spreading from that place to the CNS. And why was it shifted over to meropenem after 48 hours is slightly making me think again. After 48 hours, the child was shifted from ceftriaxone aceclovir to meropenem and vancomycin, right?
Within 24 hours, sir. Within the second day, because the child had depressed sensorium further deterioration. So we thought we will cover with a better antibiotic cover for the meningoencephalitis. Because for meningitis, obviously, we know that we need a better cover like meropenem and vancomycin initially. So till we at least have a particular microbiological diagnosis.
Okay.
So, and even if there is any as such, since you were telling even about the retropharyngeal, any cause, anything, any collection for a better anaerobic cover also is not only because ceftriaxone is not going to give a good anaerobic cover. So we wanted a both broader coverage with gram negative, gram positive, and also for the anaerobic cover, and even including MRSA coverage also. For that only we had added all these.
Okay. Have you aspirated the lymph node that is there, because it was that was the point where it all started, the swelling in front of the ear.
Yes, sir.
And that would give us a clue that which organism is there, because it all started with the swelling from the ear, in front of the ear.
Yes,
and
sir.
there was a bite mark. So whatever organism was there, from the rodent bite, cat bite, or some dog bite, whatever it would have localized to that area. And if you aspirate that and take a sample for blood culture or gram staining or all stainings, we could probably elaborate more or give specific treatment for this child.
Yes, sir. Because the child was intubated on second day, we had not progressed with that aspiration as such. So, so any other points which you had to include, sir? Anything else? Shall I progress with case, sir? Further?
Maybe Balasubramaniam sir can give his inputs, whether we are straying away from discussion or.
Okay, thank you, Vikram and Mahesh. Fantastic discussion. Now, a few comments. One, I'm not very clear whether from your description, this child is having a lower motor neuron lesion or an upper motor neuron lesion. I'm not very clear, because you didn't mention anything about the eyes. You just mentioned only deviation of the face, because that makes a lot of difference to me. I'll tell you why. First thing is, first point, I mean, forget the diagnosis. The first learning point for me, this is not Bell's palsy. This is not garden variety Bell's palsy. For the following reasons. One, Bell's palsy is very unusual in infancy. Bell's palsy is not associated with the swelling in the parotid region. Bell's palsy is usually, it's a clinical diagnosis where you don't get anything other than seventh nerve palsy. No other symptom. Fever will not be there. Pain will not be there. It will be only palsy. And the pathogenesis itself of Bell's palsy is poorly understood. They say that it is due to edema at the stylomastoid foramen of the facial nerve. And Bell's palsy can be viral. It can occur secondary to herpes zoster. It has also been reported in isolated fashion in poliomyelitis. Any acute viral infection, mononeuritis can occur, causing Bell's palsy. And Bell's palsy, one should not be giving steroids if you think of other conditions. So that is one learning point. This child should not have received steroid. I saw in the first slide, child received steroid. That is number one. Number two, if it is a lower motor neuron lesion, then in a child who doesn't have hemiparesis or monoparesis, a lower motor neuron lesion with a swelling in
So we lost you.
Hello?
We are losing you, sir.
Am I audible?
No, yes,
very
sir.
feeble, very feeble. Now, yes, yeah.
I'm sorry. There's some problem with connectivity. No. What I'm trying to say, if it is an upper motor neuron lesion, a brainstem cause is more likely. If it is a lower motor neuron lesion, particularly the swelling in the parotid, the paralysis is likely to be due to a local cause. But the fact that there is gag reflex which is affected and there is drooling indicate that the lower cranial nerves are affected. So you don't get a Bell's palsy or a lower motor neuron seventh nerve lesion just like that. So there must be some lesion in the brainstem which is possibly causing multiple cranial nerve palsies. That is my comment number 2. Comment number 3, I think before change of antibiotic, the first thing I would have done is a neuroimaging in this child. A neuroimaging is absolutely indicated in a child like this who has got multiple cranial nerves, involvement, to look for an abscess or a focal cause in the brainstem. Focal cause in the brainstem. Last is, in this child, I wouldn't be giving acyclovir at all, because you just said this child is drowsy. Unless it's an acute febrile encephalopathy, there is no need to consider acyclovir in a child who has got what looks like a space-occupying lesion in the parotid region. So I wouldn't have given acyclovir. I might have covered for staphylococcus, particularly methicillin-resistant staphylococcus. Vancomycin would have been there right in my initial thing. And of course, ceftriaxone, whenever there is it wouldn't do well against MRSA, but it would cover MSSA and it would penetrate well into the CSF. Ceftriaxone, vancomycin, and I don't know if I'm going to think of an animal bite to cover the zoonosis. I don't know. I must refer to microbiologists and find out if I should add a quinolone also to cover some of these rare organisms. These are my thoughts. And certainly, I might not have considered acyclovir in this child. Neuroimaging would have been my first investigation before change of antibiotic. Thank you very much.
Thank you, sir.
Subbarao sir wants to add something. Welcome, sir. Nice to see you.
My thoughts on the neurologic findings. There is no doubt that the facial is LMN because we don't have description of the eyebrows and things like that. But the initial suggestion of a saline difficulty in drooling definitely puts the problem on the bulbar. So this child has got a bulbar palsy with 7th nerve. That's what is my thought. And in our original days of poliomyelitis, we used to see this bulbar palsy. And enteroviruses are the ones which can cause such a problem, bulbar lesion. So I would keep that as a possible differential in this patient.
Thank you, sir.
Okay, so thank you, sir.
It's really getting heated up, whether it's LMN, UMN. The points in favor of LMN here are, significant deviation, unlike in UMN where you don't really have a significant deviation. And nasal regurgitation, you will never come across in a UMN or a nuclear lesion. Absolutely. So these two are in favor of LMN. Let's see.
No, the nasal regurgitation will not occur in lower motor neuron facial weakness alone.
No, not facial. Not facial. Not facial, sir. Bulbar pulses.
The only way I can tell
the presence of nasal regurgitation and the gag reflex being weak indicates that there is a lower cranial involvement.
Yeah.
And that lower cranial involvement
is bulbar.
Likely to, your lower cranial involvement, you should always think of a lesion in the brainstem. And if there is a lesion in the brainstem, even the 7th nerve involvement is likely to be LMN rather than UM.
Yeah, absolutely, sir.
If you have done a jaw jerk, exaggerated jaw jerk, it will tell you it's a pseudobulbar palsy, which is actually a UMN, which is not done in this patient.
Yeah, so this is probably, as you said, sir, bulbar with
there's a combination of 9th and 10th along with 7th. So we have to look at the nuclear or intranuclear regions of these places.
Basically, multiple cranial nerves, lower cranial nerve palsies with 7th nerve palsies, maybe lower motor neuron, but rather unusual. 7th and then 10th and 11th, something become, unless you have lesions which are there in multiple sites in the brainstem, unusual, and it's not likely to be garden variety again, meningoencephalitis. You don't get, brainstem meningoencephalitis like this with this sort of presentation. What is called PICU meningitis, which used to be described in tuberculosis, syphilis, etc., only such lesions will cause. This is rather unusual. And with the background of a child who has had animal bite, some organism which is localizing and which is causing pus has to be thought of.
Right, sir.
Unusual.
And were attempts made to rule out HIV in this child?
Yeah, it was made. The investigations will follow, sir. I will. So we did the. So in order to localize the lesion, so obviously we had this doubt. So as we see now, we were talking about the upper motor neuron and the lower motor neuron lesion. So here we did not find any discrepancy in the forehead, the folds of the skin. So it was more of in the lower half of the face the involvement was there. So so in order to localize the lesion, so we did the CT scan. That was the investigation which we had done initially. So which had shown multiple cortical, subcortical, basal ganglionic, and left inferior cerebellar peduncular lesions with likely eccentric focus of bleed and mild perilesional edema. The findings were mostly suggestive of toxoplasma or septic emboli, and they had also given us to give us a suggestion to rule out even retroviral status. And they have asked for a MRI with perfusion and spectroscopy was advised. So, and we had done the repeat of the blood investigations on day two also. There was no further worsening of the counts. And initially, we had not done the procalcitonin, but the second day when the procalcitonin was done, it was 3.3, and the CRP remained to be negative. So we did the other blood investigations as requested. So even the HIV also was being done. So HIV, the antibody test 1 and 2, which were negative, the rapid test. Along with that, we did a torch panel also to rule out the toxoplasma and CMV. So those had turned out to be negative, except for the HSV serology, that is the IgM, had turned out to be positive. And HSV IgG was negative. And the blood culture report was available by the end of 48 hours, which was no growth. So also we had done the to rule out any septic for emboli. For that, we had done a 2D echo also, which has turned out to be normal, which don't show any evidence of any vegetations. And also eye evaluation was done to look out for any chorioretinal changes and retinitis changes or uveitis, which was not present, and it was normal. Once the child was stabilized, even the CSF analysis was done, and that had shown evidence of increased WBCs, which was 44, and which was lymphocytic predominant. And also there was no RBCs. The glucose was on the lower side, which was 59. Protein was normal. And we did a biofile meningitis panel on the same CSF sample, which had shown negative. And also the investigation for tuberculosis, the AFB stain and gene export also was done. And we had repeated a HSV PCR in the CSF, which had turned out to be negative. And India ink preparation also was done, which was negative. And we had also sent a toxoplasma PCR and a CSF culture from the CSF, which the reports were pending. And these were the organisms which are included in the meningitis, meningoencephalitis panel of BioFire. So these organisms were ruled out. And also the MRI brain also was done. So that had shown multiple cortical, subcortical, basal ganglionic, cerebellar, and left inferior cerebellar peduncle lesions. Same thing as the CT with eccentric nodular focus of enhancement, micro bleeds along the wall, mild perilesional edema, mostly suggestive of infective etiology. Also, MR spectroscopy was done, which had shown that there was a reduced NAA peak and also elevated lactate peak. So this was these were the evidences available. So, so what is your opinion at this stage, sir? And would you like to do any further tests? And which antimicrobials would you consider?
Serology of HSV 1 and 2 are positive, but that doesn't give that he is suffering from herpes simplex virus. Just because it is positive IgM, it doesn't tell us, because it has got positive sensitivity and specificity is very low. But CSF HSV PCR is negative, means probably we are not dealing with herpes simplex virus. We are dealing with, my diagnosis will go again to the animal bite that focus and we have to aspirate that. And there is some organism which is not covered with this all antibiotics, like tularemia probably, or something, Bordetella hensali, but it will be covered by this meropenem, Bordetella hensali. We'll like to go with that only, because there is some organism which is not covered with this meropenem, vancomycin, all this stuff are acyclovir also. And baby is deuterating, and it has prediction for the brainstem. Pons and medulla are majorly involved, and that's why we are getting the 7th nerve and 9th and 10th nerve pulses here. And that too on one side only.
Could you just go back to the reports, please?
Yes, sir. So this is the CT report, sir.
Yeah, I mean, we are dealing with there is meningoencephalitis definitely, but we don't know which bug it is, and it is an acutely progressive meningoencephalitis. Probably a bug which we are not sure about. And while you are doing this, after you have started the antibiotic or hiked the antibiotics to meropenem and vancomycin, how did the child behave?
The child did not show any major improvement. So the child was still intubated, but the vitals were still stable. So there was no deterioration or improvement.
So basically, the child was ventilated for decreased work of breathing.
Decreased work of breathing and pooling of secretions, basically.
Yeah. And did the encephalitis or the signs further progress in the sense?
Yes, so that started to progress. That I'll be bringing it the next further slide, sir. So the child started to progress. There was further worsening of the encephalitis.
Up till now, it was a localized brainstem encephalitis, and that's why it was drowsy, because there was no papilledema, you said. And MRI also doesn't show cortical involvement. Only brainstem involvement was there in MRI.
MRI shows multiple cortical, subcortical.
Cortical also means it was disseminated.
Cortical, subcortical, basal ganglionic, cerebellar, and even inferior cerebellar peduncle. So all these areas were involved, sir.
Okay, means it was disseminated disorder, not to the localized only. Yeah.
Okay. Now few comments on the MRI and the lab findings.
Yes, sir.
See, in a child like this who has what looks like brainstem encephalitis, fever is not a prominent symptom. You have animal bite exposure, and you have a negative CRP. This is not likely to be, again, garden variety bacterial meningoencephalitis. That's one. I don't think we are dealing with H flu stuff like that. That's one. The second is, this is not brain abscess, the multiple lesions. The third is that HSV in serum report, IgM, IgG, should go only into Bay of Bengal. It has no place in the investigation. On HSV PCR. And HSV PCR, if the CSF testing is done 5 days within the onset of illness, yes, it can be false negative, but otherwise it's very, very specific. If it has crossed more than 5 days, HSV PCR being absent is against a viral encephalitis. I think one thing with animal exposure, this can well be rabies itself. It's not ruled out with the presentation. Yeah. Rabies can cause ascending paralysis, descending paralysis, Guillain-Barré-like lesion. And 8-month-old baby who's intubated, you might not be appreciating your what is called hydrophobia, etc. This can still be rabies. That is one disease which has not been ruled out. Second is whether this is something para-infectious, because the CRP is not high, fever is not prominent, multiple lesions, cortical, something para-infectious is happening. Unusual organism like, amoeba, crazy fungi, which are not picked up in the biofire and other things. I think the next investigation I would consider will be a tissue diagnosis and a pathological diagnosis. And I will try to find out, Dr. Archana didn't tell us more about the swelling. I might be tempted to do a biopsy of the lesion, which is there available to me, or worst come worst, I will consider doing even a stereotaxic brain biopsy for diagnosis, for accurate diagnosis, before which I will definitely give the serum CSF sample to a veterinary hospital for confirming whether it is rabies or not.
So regarding the swelling, so because the child was deteriorating, so biopsy couldn't be planned. So that was the issue.
Yeah.
That is first thing. Second
what about rabies testing?
Rabies testing, sir, the MRI picture, because there was multiple hypotense lesions. Usually in rabies, there is more of a lenticular involvement, no, sir, lenticular and thalamic.
You can't rule out because you have aseptic meningitis. You have aseptic meningitis. You have multiple cranial nerve paralysis, and you have basal cranial nerve involvement. Atypical rabies is not ruled out. Animal bite exposure. You are given ARV. The child has received ARV. That means you have suspected the rabies risk.
Yes, sir.
And amoeba, amoebic meningoencephalitis can exactly present like this, and it requires a good microbiological diagnosis. That's one other disease which I will definitely consider.
So whether that swelling was fluctuating, Archana?
Sir?
The parotid swelling, where there's
no, so that did not further increase. It was not increasing, but yeah, it is this thing mobile. It was mobile, but it did not further increase in size.
But can you aspirate that?
It was not cystic. It was not cystic. It was firm, consistency.
FNAC could have been done, not biopsy. FNAC.
Not biopsy. FNAC could have been done. Was not done, sir.
Okay. Was there a role of starting metronidazole here? Sir?
Metronidazole for which particular coverage, sir?
Anaerobic.
Because the child was already in meropenem, so meropenem covers a good anaerobic cover.
We are also thinking of something else, which may not be covered by meropenem. Metronidazole, I don't know.
So
Balu, sir?
The other thing is,
when you get multiple lesions like this, the diagnostic possibilities are amoebic meningoencephalitis with multiple nodules, neuromyeliidosis, neurobrucellosis. Last is some secondary to some tumor, secondary in leukemia or lymphoma. These are the possibilities I would consider. And I will see whether I can get a tissue diagnosis anywhere and perhaps consider doing a bone marrow in this child. And then, if that also doesn't give me a clue, stereotaxic brain biopsy.
And for melioidosis, usually we do have other lymph node and any pulmonary involvement also, no, sir?
Not necessary.
Not necessary. Yeah. But there was no any other organomegaly.
We have seen neuromyeliidosis cases going on for 6 months.
Okay.
Ultimately, brain biopsy going cultures. So that can happen. Notorious.
Okay. So we did consider even CNS toxoplasmosis because there was multiple
fundus changes. Any chorioretinitis from the ophthalmologist?
No, sir. Ophthalmology, the examination was completely normal. Retina, everything was normal. So no chorioretinitis. So we had done that also. So fundus and echo both were normal.
Okay.
Yeah, I mean, looking at how the child has progressed, especially with the parotid enlargement, parotid gland, and further progressing in a matter of few hours, looks like cat scratch disease is probably higher on the cards.
The cat scratch disease, but we have not covered with azithro or doxycycline. So that is one thing I think which we have.
Yeah, so that is what I just wanted to. Yeah,
that's why I said that initially that bite marks may be because of cat and that rodent, whatever. You have to cover that atypical aneurysm.
Yeah, we have to cover even the streptomycin also for the rodent thing, for the rat bite fevers and all this stuff. So those are the things which we have not covered.
Because they started with the bite marks and then the swelling was there. That was a point for that.
If it is an animal bite induced unusual infection, most microbiologists or infectious disease consultants would prefer to give moxifloxacin or revofloxacin IV.
Yeah.
DNS penetration. Unusual organisms. Extend the coverage.
Did the child
have doxycycline, sir? Doxycycline?
That should be okay. But there are certain pastoral and other things they may not respond.
Yeah. That is our first thing. It is unusual organism, started with animal bite, had a parotid swelling, and it progressed from that. So we had a tissue there. We should have aspirated and get the diagnosis.
But again, CRP is not elevated.
But unusual organisms will not, CRP may not be that helpful.
Child,
We don't know. We don't know.
Not a prominent symptom.
Yeah.
Nothing else is happening. Unusual. Yeah.
Anything happening in the lung?
Lungs was completely normal. So the chest X-ray had been normal, though later there were some complications because of the intubation, but otherwise in the initial stage there was nothing.
Okay.
Yeah.
So in hindsight, you think we should have the child should have been on doxycycline or streptomycin, is it?
Yeah, there should have been some additional for the atypical bugs also. So,
but we were right from the time the child was admitted thinking of an atypical bug. So that's one of the reasons why we kept on asking why only meropenem or and vancomycin were added, because if we were to put all these things together, if we really take the child being abandoned and all these bites are significant, then the child should have been on all the coverages. Yeah.
Yeah, I think that is one of the things, like doxy or azithro, I think should have been there at least. That or as I said, levofloxacin should have been added.
Yeah, fluoroquinolone. Yeah. Because does doxycycline have a good brain barrier penetration? Unlikely.
I think for that, levofloxacin would be much better.
Yeah, so fluoroquinolone.
Yeah, fluoroquinolone should be a better choice. Yes, sir. Yeah. So here, since there was no improvement, then this child was also started on cotrimoxazole with clindamycin for the possible CNS toxoplasmosis, because the pyrimethamine was not initially available. So we did not have the pyrimethamine sulfadiazine combination, which was available in our pharmacy. So then we have procured pyrimethamine.
Why was toxoplasmosis thought of in this child?
So this child actually in the MRI, sir, because there was multiple hypointense lesions. So even we thought of even the parasitic infection also. We wanted to cover even for the parasitic infection in the background of your, because the child was found in the garbage and all this stuff. So obviously we were thinking in terms of toxoplasma also. That is one thing which we had.
Would acute toxoplasmosis be so, so rapidly progressive?
This child...
because the child was with you for some time. And got acutely ill.
Yeah, quite acutely ill.
So acute toxoplasmosis.
Because there was no response, obviously we had increased the cover for the parasitic infections also. So,
okay. Less likely,
so we had added on along with the antibiotics. We thought we will cover even for this other organisms, the atypical organisms, and this one for the parasitic infection also.
Balsubramanian sir, can acute toxoplasmosis? I've never seen a child with acute toxoplasmosis, sir. If you could, I don't know.
I have not seen. I'm afraid I have not seen. I've seen congenital toxoplasmosis.
Yeah.
Acquired toxoplasma like this, I have not seen. I have seen 1 or 2 cases of retinitis referred for management, but I have not seen this sort of. But if the child is immunodeficient, yes, it is possible. But the blood counts being normal, and of course, though it's an orphan child, exposure to animals is there, so you have to consider one of the possibilities. Okay. But again, final diagnosis, I need a tissue diagnosis. I don't think I will make a diagnosis.
MRI is also not suggestive of toxoplasma. MRI was typical of toxoplasma?
Toxoplasmosis is not, in today, 2023, CMV and toxoplasma are not diagnosed with imaging or IgM tests.
Okay,
you
PCR.
have PCR for everything.
PCR for everything, yeah. Okay.
Yeah.
We'll go ahead.
Yeah. So also we had added an antifungal also. So liposomal amphotericin B also was added because there was multiple hypointense lesions. And one thing is, since the MRI...
Just a second. What did the... did you get it reviewed by another radiologist? Because what exactly were those hypointense lesions? Were they infarcts? Were they... What exactly were they? For us, it is very important to know what exactly were this. Those hypointense lesions, whether lacunar infarcts or what exactly were they?
Vikram, you are interested in small vessel vasculitis like thing?
No, not at all.
Not at all. Okay.
No, I just wanted to know because
you said
they just give us a if they just give us a report as hypo-intense lesions, what exactly are those hypo-intensities? That is what we need to know.
Even cysticercosis can present a picture like this.
Absolutely, sir. That's why. What
exactly? Almost like starry sky. I mean, it tells you it's multiple nodules. That's all. With this, you can't make any diagnosis at all. It's only multiple nodules, which can be bacterial, fungal, or tumor. That's all I can say. Only thing, this is not a bleed. That's all I can tell.
Absolutely not a bleed, sir. But they also have. You also mentioned about certain peaks. I mean, what exactly did we learn from those peaks?
Lactate peak was not.
So one thing is, first they say that few of these lesions, hypointense lesions, were showing some eccentric nodules with the walls of the lesion showing some bleed, some blooming, which was suggestive of bleed. That's mentioned in the MRI. So that one, and MR spectroscopy with reduced NAA peak and elevated lactate peak actually can be seen in neurocysticercosis, the reduced NAA peak and the elevated lactate peak in terms of infection. So, usually this sort of a picture will not be seen with your the tuberculosis. Neurotuberculosis is the possibility comes down with the reduced, but they have not mentioned on the lipid peak. Lipid peak is which is important, which is not.
No, I mean, in the context I'm asking because it just looks like something is just getting embolized and just getting lodged everywhere across the brain. Something has happened here locally or somewhere. And it's emboli of certain things that is happening and just getting lodged across the brain.
But emboli, bleed and all will have caused a lot of anemia, so much of bleed.
No, sir. Small septic emboli.
Pathologically, nothing is happening.
And also the echo also was normal. So.
No. I mean, not exactly that. I mean, some local infectious, acute infection, which is just getting disseminated inside the brain, hematologically getting spread locally. Okay. Usually, I mean, when we get a review of the MRI done, most of the radiologists give us certain differential diagnosis in an acute process like this. So I just wanted to know what their opinion was, because MRI and a lot of radiological signs are there. So they just gave it as some acute encephalitis, is it?
Yeah. So they just mentioned it. This is what they had given, sir. They were thinking in terms of more of a fungal they had given all possible possibilities, actually, parasitic, fungal, and bacterial and tubercular. So should we consider tubercular etiology in this time?
I think it's a very broad-based, safe diagnosis. The radiologist respects to that. Yeah, I'm just telling you, there is no way you can make a diagnosis.
Yeah.
Get that tissue.
Absolutely, sir. Absolutely, because even this,
you see, the days of only looking at the shadows and giving a confident. In fact, I'll tell you, in 20 years back, any ring lesion in the brain, everybody was starting ATT. Then they woke up. They started picking up cysticercosis. Now they have woken up. Even after a seizure, you can get a ring lesion. So like that, when you get multiple shadows like this, your differential diagnosis is enormous. I don't think it can be made radiologically. It has to be made only histopathologically and microbiologically.
Balasubramanian sir, I was asking all these questions because I work in a very resource-poor setting. So I just wanted to know whether any phenotypical clues I have so that I can come up with certain phenotypic diagnosis. That's it. Because I won't be able to do any of these things here.
Yeah, unfortunately, it's not possible. It's not possible.
Correct, sir. Thank you.
And should we consider tubercular etiology over here?
No,
acute like this with the CSF, definitely it would have picked up gene expert it would have been picked up by gene expert or by a smear, and there might have been other clues in the chest X-ray or other ways. Okay, I don't think I will consider. Of course, in India, tuberculosis can present any way it likes. You can have normal CSF, but I have seen cases of tuberculosis meningitis is completely normal CSF. And AB being positive, that can also be there. So it has to be considered, but it doesn't look like that. I'm sure you would have done CBNAT in this child.
Yes, sir. So we did CBNAT in CSF, which turned out to be negative. So we did further investigations to look for any evidence of tuberculosis elsewhere also. So we did the chest X-ray, which was normal. ET aspirate also was sent for gene expert, which had turned out to be negative. So also we did for neurocysticercosis, the ELISA, which had turned out to be negative. And also for cryptococcus, we did the India ink stain and also culture, which was done, which turned out to be negative. And finally, even the bacterial culture and the fungal culture of the CSF also was negative. Toxoplasma PCR also turned out to be negative. So there was no microbiological evidence from all these investigations. So by day 8 of admission, the baby was had suffered a cardiac arrest with ventricular tachycardia, which was revived with CPR. And there was further progression, and there was cerebellar involvement, and we could see nystagmus, and there was a central diabetes insipidus. And finally, the child had some complications with the intubation. Also, there was some aspiration pneumonia, had developed a VAP, had developed tachycardia with fluctuating blood pressure. So added on to the sepsis of this child. So any further diagnostic test other than this to confirm the diagnosis? Any other tentative diagnosis which you would consider? Any further change in the antimicrobials or any other change in treatment?
So at any point, considering all these rodent bites or cat bite, was it considered, and was there a role to add rifampicin early years, sir? I don't know.
And here at this point, doxycycline was added. In the starting, it was not added, but later the doxy was there.
And levofloxacin was added?
Improvement.
Levofloxacin was added?
No, sir, no levofloxacin.
Okay.
No, right now we don't have any clue as to what is going on. We just know that we are dealing with an acute severe meningoencephalitis, brainstem, and also disseminated across the encephalon. So we have no clues what is going on. Balasubramanian sir, you'll have to help us.
The only thing I would have given is an antifungal amphotericin. I'm sure they would have started earlier also.
Yeah, that was started, sir. It was already given.
I don't, I mean, in such a situation, you want to cover everything, it's not possible. At this point of time, you want to cover fungus, you want to cover amoeba, you want to cover virus, you want to cover bacteria, you want to cover TB. It's not possible. I don't think at this point of time I have anything more to do other than perhaps consider doing one more lumbar puncture. But in a child who's ventilated, who's having so much of hemodynamic disturbance, I wouldn't do anything. Simply wait. Of course, I would have repeated the counts and find out whether there are any other clues. For example, a leukemia showing up now, the lymphoma showing up now. That's what I would think I would do rather than simply change the drugs.
Now, hepatosplenomegaly is developed in the child?
No, sir.
At this point of time?
There's no further any lymph node involvement or hepatosplenomegaly. So
there was only purely meningoencephalitis and
meningoencephalitis with the added on complications.
In fact, biopsy of the node, the parotid region swelling, at least FNAC, definitely I would consider doing. I must look at the tissue. It is likely that the nodule that you get at the parotid side may be similar to the nodule you are seeing in the images in the MRI.
Okay, sir. So,
looking at how the child has progressed, it cannot be a routine bug. As Balasubramanian sir has been telling right from the beginning, it cannot be a routine bug. Even if it's a routine bug which is not sensitive to routine drugs, is also not a possibility. We are probably dealing with a bug which is
I would go further saying that this may not be infection. This may be infection. If it is infection, it is an unusual infection caused by an unusual organism with unusual findings. The second possibility, it may not be infection. It may be an infection mimic, like a granulomatous lesion or a tumor or a malignancy. Okay. Third, there is a possibility it may be a combination of an infection and a non-infective lesion. For example, a child having a lymphoma or a leukemia, also having an unusual organism causing a granulomatous lesion. That's what I would think of. Last is, this may not be infection, this may not be inflammation, this may simply be a vasculitis. For the age of the child, 8 months, rather unusual, para-infectious encephalitis, para-infectious vasculitis. That's what I would think of. But I know for sure if this is going to be a microbiological diagnosis or a pathological diagnosis,
it has to be the biopsy.
An organism like amoeba or some rare fungus or meliard or brucella, things like that.
So as sir said, brain biopsy was planned. but it was deferred since the child had cardiac arrest, which was being revived later. But the baby expired by 12 days of hospital stay, and then brain tissue was sent for biopsy post-mortem. And this is what it showed. So we could see the trophozoites and the brains, the cyst, encysted cysts. So here, these are the large coalescing necrotizing lesions, which were seen involving the insular cortex and the putamen with extensive perilesional edema. On histology, there was dense vasculitis and inflammation. Large trophozoites forms with prominent nucleoli was seen. Thick walled cyst form of acanthamoeba was seen. So H&E stained sections of the patient brain tissue reveal both trophic and encysted amoeba, acanthamoeba. As SBS sir rightly pointed out, it was a amoebic infection. So this is what we had found. Okay. And so could this have been diagnosed pre-mortem? Is there any other diagnostic test which we can do to find out such sort of infections?
So were those bites and the parotid enlargement were red herrings in this case? Were they of no significance while we had to take into consideration the way the child progressed?
It could have been a red herring, sir, but or it could have been a point of entry also, don't know. But acanthamoeba is a condition where it actually stays for longer duration. It can present even after weeks to months, actually. So not sure. This child had most probably the dog, the bites, whatever the bites, 3 weeks prior to the admission. So could be a cause. Because the child was found in the garbage also. It's because this particular amoeba and all can be found in the sewage, soil.
Absolutely.
So it can be there.
Yeah, any contaminated pond, lakes and all. So there are anecdotal reports. So
we have been get this amoeba in that parotid tissue, that swelling. That is my question.
If that was there, most probably we could have got, but I don't know if FNAC would be able to get it. So will the FNAC be enough to get this organism, sir? Or how is it?
I don't know. I have not, to be very honest, I have not seen a case of maybe meningoencephalitis. I have two organisms you always consider when you are meningoencephalitis is not responding to your restrictive. One is another is of course fungus, and of course other than melioidosis and brucellosis. So I have no clue. I guess you should be able to pick it up. I don't know. PCR may be there. I don't know. I'll have to read. But to be very honest, I don't know much. Maybe others. You can tell about it.
So for acanthamoeba, they say immunoperoxidase test or the immunofluorescence staining is the one which we can do to diagnose the condition. And also tissue PCR on the, can be done to diagnose the condition. So, but CSF alone will not be able to diagnose the acanthamoeba. With the free forms of the acanthamoeba will not be found on the CSF. So we need a tissue diagnosis. So biopsy is the diagnostic investigation of choice for this. And so otherwise, getting it in a pre-mortem, doing a biopsy of the brain and getting this diagnosis would have been a tough choice. But obviously, lymph node, we could have tried the biopsy. That is one thing.
But I don't think it would be we would be able to get it from the lymph node. And was it the portal of entry at all?
Don't know. That's the thing. If it was there, then most probably would have got it. Otherwise, or is it because the red herring?
Acanthamoeba encephalitis, the portal of entry would be either inhalational or through the contamination of the wound and all.
It's more of a hematogenous spread test seen with acanthamoeba.
But the child, the story goes like this. The story has started with the bite. Then he had a right swelling in front of the ear. And then you have to correlate that.
So that is what, sir. It looks like all those things are red herrings here.
Yeah.
The bite and all the bite must have just been a portal of entry for the
because he was in garbage area.
Yeah.
Other thing is, sir, because this child was in a peripheral hospital and had received steroids for the Bell's palsy, the steroids actually can worsen the progression of acanthamoeba. Acanthamoeba usually will not go with such a rapid progression of illness, and there won't be so much of a. It shouldn't have caused of a mortality in such a early, duration. Might be if it was a Naegleria, then it could have caused such a rapid progression. But acanthamoeba could have it was actually slow progression, but the steroids could have aggravated the issues.
Induced immunocompromise.
The only thing now, in the hindsight, it looks like, because I don't know whether acanthamoeba induces a granulomatous inflammation. I have to go back and read. So probably whatever happened there were probably an acute granulomatous inflammation across.
Yes, sir. Acanthamoeba causes granuloma only. So it is a granulomatous meningoencephalitis.
Oh, so okay. So that would explain why the child had multiple
vasculitis
hypodense. Yeah. Okay. Thank you so much.
Thank you.
Thanks a lot for your input, sir. Thank you.
Enjoyed the case, but
yeah, absolutely.
You can stop sharing, Archana.
Yes, sir. Stop sharing. And thanks a lot for Jagdish Chinnappa, sir. It was his case, this case.
Actually, the problem here was also social, because this child was abandoned. There was nobody who was willing to give consent for many things. So the caretaker, we had to get all kinds of manipulate for even getting the simple ventilation. We had to get different kind of permissions, go to different people to get permissions. All that challenges were there to even get a simple ventilation going in this child. So there were too many social challenges and procedural challenges in addition to all the problems we had. So I think the exact route of transmission is not clear. Still, they are not very clear about what is the exact route of transmission. But as Vikram said, it can be nasopharyngeal or break in the skin, one of the two. That is a common thing, and it can basically cause necrosis and inflammatory processes. And brain autopsy causes cerebral edema, hemorrhagic infarcts, trophocytes and cysts, and histological findings which have already been shown, and also can cause thrombosis. So all the findings are there in the MRI as well as the biopsy. So I think this is a very unusual case, and I must congratulate Dr. Bala SBS for even considering it. He mentioned very clearly about amoeba. So I think these are a challenging case, and we had a tough time with this child. So anyway, so we could at least get the diagnosis.
Sir, you had considered acanthamoeba encephalitis or Naegleria fowleri encephalitis, sir, because that is also called as
we considered amoebic.
No, I was asking Balsubramaniam, sir.
No. See, how many cases? I have not seen a case. See, when I just thought of it. See, only fungus or amoeba are the two organisms where you don't think of. If it is only a HSV, if it is only T, Archana won't be presenting. that gave me the clue, not the clinical picture. Okay?
Right.
The clue was from the presenter and not from the clinical status. Okay? The clue was not there, not because I have seen hundreds of cases. I have not seen. It's all seen in textbooks. You mentioned, in fact, I still remember, if I remember correct, I think in one of the, Archana, you can check up, in one of the case records of Massachusetts Hospital, a very similar presentation, I think, of amoebic meningoencephalitis is there.
So that is Naegleria fowleri, sir.
Yeah, something like that is there.
Because acanthamoeba meningoencephalitis is very rare. I have not even heard.
Very rare presentation.
In fact, we have had problems like this, meningoencephalitis without a diagnosis. And I can tell you what our experience has been. One turned out to be an unusual lymphoma. One turned out to be neuromyelioidosis. We are surprised. Myelioidosis, because we couldn't pick it up from the blood culture or from the bone marrow culture. But the brain biopsy culture grew myeloid, and the child improved dramatically with septicemia. And third case was, of course, HSV. The HSV CSF was negative, but from the biopsy, the HSV was positive. I mean, these things can occur. In fact, literature survey suggests that in HSV meningoencephalitis, even your PCR can be negative for up to 30 days. There are case reports where they have diagnosed HSV meningoencephalitis after 30, 40 days in cultures. Viral culture they have started doing. So, I mean, modern technology is helping us to diagnose all these rare diseases. Excellent presentation. Good learning from Archana and Jagdish. Fantastic, Jagdish. Well done.
Thank you, sir.
Right, sir. Thank you so much.
Thank you so much.
Thank you.
Thank you.
Thanks a
Thank
lot
you.
for the learning points, sir. Thank you.
Acha, by the way,
Thank you, SBS sir.
Just last point. I'm just looking at the current treatment, and it says vancomycin, ceftriaxone with amphotericin B.
Yeah, Ampho B will cover acanthamoeba.
So,
And is it almost routinely fatal, sir?
yeah, the very few case reports.
Almost always fatal, because
and many people have tried different combinations. Some have tried meropenem, linezolid, moxifloxacin, fluconazole. So there are at
they've
least
had
about 5
okay, they've done living brain biopsy while the child was there for confirmation.
Yeah, the other point
Antemortem.
is you should
most
do
cases are diagnosed post-mortem.
Yeah, post-mortem.
At least if the baby had been alive, you should do an immunodeficiency workup for this child. Unusually, no, I'm just saying.
No, I think with this kind of bad prognosis, I won't do any testing on this child.
No,
I would move towards full palliative care.
No, I'm talking about diagnosis for counseling. If it doesn't turn out to be an orphan, if it's a routine child, definitely for prognosis and counseling, immunodeficiency workup is mandatory.
True.
Correct. Absolutely.
And Fecan and Cherry actually gives one 4-drug combination therapy, sir. Pentamidine with sulfadiazine with ketoconazole or itraconazole and rifampicin. All 4.
the Archana, if you look at the 5 cases reported, all 5 have different regimens, and none of them have survived.
Correct.
So
They have tried different things. They've given a list of medications, and finally they said this can be tried. This is the 4-drug this thing.
Okay.
Just as a last thing, I mean, did you try to rule out rat bite fever and cat scratch in this? Any specific investigation you got done in this child? No.
Didn't look like.
Because cat scratch, there are few case reports. Just now I was going through, can be acutely progressive like this. Small children.
Okay.
Right, sir. So thank you.
Thank you so much.
Okay. Thank you.
Thank you, Balu sir. Thanks, Kore sir.
Bye.
Thank you, Vikram. Thank you,
Bye,
sir.
Have a great day.
Thank
Bye,
you all.
Chinnappa sir.
Thank you.
Bye.
Yeah. Bye, sir.
Bye. Dr.
Thank you, sir. Thank you all for the wonderful
Subramanian
case
sir,
there. Yeah, and we move on to the next presentation. We have a kind of a debate, the pro-con debate coming up there. And to chair the session, we have the teacher of teachers, Dr. Subbarao sir, coming in as the chair. Sir does not require any introduction. He's currently the senior consultant at Manipal Hospital. He's been the former professor and head at St. John's. He's been the former president IAP Karnataka chapter, and also he has multiple publications and he's been at major forums, chairing sessions and delivering his clinical pearls. Thank you, sir. Thank you for accepting and being there with us, providing us the guidance. Thank you, sir. And to talk more, we have on the pro-con debate, we have Dr. Supraja Chandrasekhar madam and Dr. Maninder Dhaliwal sir joining in. Subbarao sir, it's all over. It's over to you, sir. Thank you, sir. Sir, you muted. Subbarao sir. Sir, kindly unmute, sir. Subbarao sir.
Yes. I'd like to thank the Fever Foundation and Dr. Jagdish Chinnappa on 2 accounts. One, for allowing me to be part of this wonderful program. Second, very importantly, not putting me as one of the debaters, because I would have found it very difficult to debate, and putting me as an adjudicator. However, it's a pleasure for me to introduce Dr. Supraja, who has been a consultant in intensive care. She has worked in multiple hospitals, and currently she is in DHE hospitals, and she's got a vast experience in treating very sick children, including COVID and dengue. And in today's talk, she will be arguing for doing a lumbar puncture in a 2-month-old child. Next slide. The second participant is Dr. Maninder Dhaliwal, who is the consultant and clinical lead in pediatric intensive care and pulmonology in the Amrita Hospital, Amrita School of Medicine at Faridabad. and he has got many credentials to his credit. We're wasting our time because we're already overshooting. He shall be talking against the topic, that is LP is not required for a febrile 2-month-old child. So we shall open the debate and we'll start with Dr. Supraja, who will argue for the topic. Over to Dr. Supraja.
Thank you so much, sir. Can I share my screen?
Yes, ma'am, please.
Okay, when I got this topic, I was extremely worried. How am I going to present it when the literature seems quite clear? Then I understood most debates are how you look at things. Either the glass is half empty or half full. So I am going to definitely talk about why it is necessary and mandatory to do LP in a baby less than 60 days old in certain situations. Now, as we know, about 5 lakh infants are evaluated every year for fever in the ER. And our aim is always to pick up those who have a serious bacterial infections, be it meningitis, UTI, or bacteremia. And we need to pick them up early to avoid the complications. And most often, they only present with fever, which is the only sign and no other clinical clue in most cases. And many times they don't show clinical signs. They may even look well. As we all know, there is no single lab marker which is actually found to be so good to pick up. Otherwise, we wouldn't be having this debate. Sorry, it's just getting a bit stuck. So now coming on to clinical criteria, we have criteria of how the baby just think my slides are just give me 1 second, please. Extremely sorry for the delay.
It's like Maninder is having a good time in the park.
Okay.
Ma'am, should I share it from my side?
Do you have the latest one which I've shared?
The last which I have received, I will share that. I'll just share.
Just 1 second. Let me just try one last time. Okay. I'm not sure if you all are able to see it now. Is it visible?
Yes, ma'am.
Yeah, okay. So we know that no single marker is actually going to tell us whether to do the LP or not. So if you look at clinical criteria, both the height of fever and the WBC count is not very useful. So how do we pick up those little infants who are actually at risk of SBI, especially meningitis? Now, neonates are at the highest risk, as well seen in the study, for meningitis, both bacterial as well as aseptic. So there's no doubt that we have to be overcautious when it comes to the less than 28 days. Now, between 28 days and 60 days, we still have a debate going on. So the context of the babies in less than 28 days are febrile neonates are believed to be at higher risk of bacteremia and bacterial meningitis than infants in their second month. And it almost doubles in the neonatal age group as compared to outside the neonatal age group. The complications are much higher. So I don't think on whether we need to do LP in those who are less than 28 days. The context of the younger infants are between 28 days and 60 days. We all know they have an immature immune system. They would have received only 1 dose of PCV, if at all. So they are still at a very high risk. Now, our aim is to pick up that group which is at higher risk and use some criteria where we can say this is where the LP has to be done to this cohort. So a lot of criteria have evolved with time. Earlier, we used to do CSF in everybody, and as well as a urine and a blood septic screen. But over time, we have newer diagnostic methods. We've evolved with our vaccination, and PCV has become mandatory even in our country. So hence the debate on whom we should actually do the LP for in less than 60 days. So where do we stand now? Now the question is, do we look at appearance? Do we look at blood tests or any other tests like urine tests, or look at a combination of all to pick up those in which the LP has to be done? So looking at the clinical appearance, a study which looked at about 2,000 young infants actually showed that very well-appearing febrile infants can still have a CSF pleocytosis, which could be aseptic or it could be bacterial. So just going by clinical appearance would certainly not pick up the ones to do the LP on. We need to find out those high-risk criteria. Likewise, blood analysis is not enough. No single parameter in the blood count, be it the total count, the band forms, the peripheral smear, whatever we use, cannot actually pick up those high risk only by going at blood counts. So we need better diagnostic tools. Now, most of the criteria which have evolved over time actually suggest to do the LP in those who have a positive urine analysis. Of course, now the criteria say do not do LPs as in all of them as a blanket rule. However, we need to pick up those high-risk babies who have an abnormal urine analysis, but urine analysis positive or negative does not actually tell us whether to do the LP or not. When in doubt, this paper clearly says we need to do it. So how do we pick up those risk factors in these young infants? Certainly, as I mentioned, less than 30 days, let's not have a debate. Those who are ill-appearing, yes, we will have to tease them out as the ones who would require LP. Anybody who has focal signs, anybody who has an abnormal history in terms of prematurity or received antibiotics, who have comorbidities or chronic illness or some maternal risk factors. Again, as we said in this study as well, it's a quite older study, but in them, they definitely said there is a role of LP, especially if the infant has risk factors. So there was another large study which was done, a meta-analysis published in JAMA, where they looked at 25,000 infants, and they said the prevalence of bacterial meningitis is actually low, about 0.25 to 0.44% only in those who have a positive urine analysis. So the point is not to look at the urine analysis and then decide on the LP, but the point is to do the LP in those whom we consider as high risks. Now let's try to tease out who are they. So the recommendation for the LP would be to individualize them in this cohort of those who have a positive urine analysis. Likewise, multiple studies pointing out towards the same. So if we tease out that group of less than 60-day-old baby who have certain abnormal criteria, be it clinical or be it laboratory, then doing an LP has the highest yield in them. So let's look at what are these criteria that we can use. Earlier, we had something called Rochester criteria, which looked at a bit of history, ruled out ill-appearing infants or premature infants, and then looked at blood counts and look at the band count and the urine microscopy. Again, this didn't fare very well. It fared well in picking up those infants who had UTI, but not necessarily with bacteremia and meningitis. Their sensitivity really dropped. So there were babies who were incorrectly classified. So we can't go by this criteria again. We would miss certain babies. Then came up in 2019, the big study, the American study, with the PICU criteria as to pick up those infants based on the absolute neutrophil count, the procalcitonin, and an abnormal urine analysis, and said, these are the babies who are high risk, and it fared very well with high sensitivity and specificity. But an external validation of that study in a European country actually didn't do very well. Almost 10% would have been misclassified. So just going by those three criteria, again, we would have missed a serious bacterial infection meningitis by not doing the LP. So they suggested certain changes to the PCAN criteria, like the cutoff for procalcitonin being lowered from 1.7 to 0.5. And also they said it doesn't fare well if the fever was less than 6 hours. So again, we don't have any definitive criteria to pick out those babies in which we need to do the LP. Now, what does the American Family Physician Guidelines say? It says that it is a must for all febrile neonates, that is less than 30 days, but between 1 and 3 months, the gray zone, we need to actually use various other clinical as laboratory tests to pick out that. Above 3 months, it's quite clear. Focal signs, and then we do it. Seizures, and then we do it. Otherwise, we don't. We observe. So let's look at the well-appearing, supposedly low-risk criteria. Babies, in them, we tease out high inflammatory markers, whether it's CRP or procalcitonin, look at the urine analysis and also other risk factors such as high-grade fever. And if in doubt, we do the LP. So one interesting algorithm which I found, which again shows a modification of these criteria, where they use both clinical as well as the laboratory tests to decide on doing the LP along with a backup history. So I would like to summarize that any neonate with fever, however well, must warrant an LP and a complete septic screen. But between 1 and 2 months, we need to carefully tease out with a multimodal approach. A history which is worrisome, such as maternal risk factors or prematurity or received antibiotics, etc., or chronic illness. Physical characteristics, simply a persistent tachycardia or an abnormal, clinical scoring on the pediatric assessment triangle, appearing ill, or the duration of fever when it's very low. We need to be careful in using these criteria. Along with this history, we tease out lab criteria looking at blood counts, procalcitonin, use a lower cutoff, use the urine analysis, and if any of these factors come positive, have a very low threshold of doing the LP. That's it from my side.
Thanks, Dr. Supraja. On a difficult pitch, I'm sure you batted extremely well to do for the favor. I'm sure India also will do the same thing today. And to bowl some spinners and googlers, we have Dr. Maninder Singh Dalwal, who will talk that LP is not necessary in a 2-month-old child. Over to Dr. Maninder.
Hi, good afternoon, everyone. Just share my slide. Okay, are my slides visible?
Yeah, visible. Yes.
So first of all, I must thank Dr. Supraja because she took the part which was actually difficult. You cannot do LP for every child who has a fever. That is a little too much, or should I say it's an excessive way. So remember, we are in 2023. We are not in 1990, and we are much more advanced, and disease epidemiology has changed. So with that, I like to go forward. So as my colleague has told that we might miss diagnosis of meningitis, delayed LP, delayed admissions, prolonged admissions will happen. She will quote many studies as she has shown. Most of them were before 2015. We are in 2023. And mandatory LP in a 2-month-old is not practiced anywhere in the world. Mandatory is out. That was practiced way back, somewhere in 2003 or 2004. So it doesn't go. So just asking out of curiosity, how many LP would one do in every fevered child at 2 months of age to diagnose one case of meningitis? Sir, Subhash or Dr. Supraja, what would you think?
Yeah.
How many LP will I do in a 2-month-old with fever so as to diagnose one meningitis?
So before I answer that, if I am going to pick out only what high-risk babies that I mentioned.
We are talking about simple febrile infant who comes, you told mandatory LP. I am saying as per guidelines, when LP is done, how many LP would you do to diagnose one case of meningitis? 100 LPs, 500 LPs, 1000, 4000 LPs or 10,000? Just pick a number.
4,000.
See, you do 100 LP, you're not going to pick 100 in these children. So, what does the evidence say?
4,000 is the number they pick.
Correct, sir, correct. So this is very true. We have to do 4,000 successful LPs to diagnose one case of bacterial meningitis. And this is 2023, when we have all the inflammatory markers and all our clinical skills and all our scoring systems. So this is little bit too much. This is too much. We should not do an invasive procedure in a child, in 4,000 children, to diagnose one illness. This is what the guidelines say. I am not saying. I am sure you have read the guidelines. So you almost 100,000 children you will do LP, and one might die as an unrecognized case of meningitis. So it's too big a number. Because why it has happened? Because the epidemiology has changed. So mandatory LP, then there is no clinical decision. A child has come with fever, where does the clinical decision stand? Because some guidelines say it's mandatory. Or it is evidence-based LP, where evidence and clinician leads the way. So you should do an invasive procedure when it is only necessary, because it is not collecting a blood sample. It is putting a needle into a CSF place where complications are known. And sometimes because of LP, meningitis can happen. So we have to be strict, but not that strict like Amitabh Bachchan in Diwar, that Bachcha comes to my ICU and I will do LP and only then I will send the patient out. That concept should not be there. So who should win? We'll come to that. So I'm going to discuss this in 5 points. The old fever guidelines, current guidelines, challenges to counsel a parent for doing an invasive procedure, and the clinical decision rules always. Patient first, not doing mandatory tests. That is outdated. So 1990s was the birth of all the criterias. As Dr. Supraja had told, there were 1, 2, 3, 4 criterias. If you see over here, the first criteria, SCSF was mandatory. They were doing CSF. Then the modified Philadelphia came on, where CSF became a sort of not mandatory. And ultimately, it has almost been removed from the guidelines. We are talking about beyond 1 month. So this was the first paper, 1993, the practice guidelines for the management of fever in children 0 to 36 months with fever without source. And here also, if you read properly and carefully, it says children managed in this manner should have a urine culture, but do not necessarily need a blood culture or a lumbar puncture. Beware, it was 1993, so back then. And the decision of these practice guidelines was physicians should come to a conclusion based on the clinical circumstances and adopt a variation. So nothing is mandatory. Way back in 1993 also nothing was mandatory. And this is from the same algorithm, and it says non-toxic appearing 28 to 90 days old infant, low risk infant. If it is nothing is there, then you do complete. That means if the child is toxic and a high risk, you do all this. But if it is a low risk infant, either option 1 was still lumbar puncture was there, but option 2 where was just send a urine culture and do careful observation. Because at that time, they defined serious bacterial infection as UTI, meningitis, pneumonia, bacteremia, whereas in 2023, the AAP guidelines now say that you should not label UTI and other viral infections as serious bacterial infections. You can also consider them as mild, but meningitis, because it is serious, you should target it separately. So that is what the AAP says now in 2023. They say do not just use the umbrella term of serious bacterial infections, because the management of UTI is early diagnosis and early treatment. And you club all these fever children, and then you say because there were 100 UTIs, you do LP in one. That doesn't add to the calculation. So over the years, many number of studies, and there's a declining trend of performing a lumbar puncture on low risk. This was way back in 1990s also. We are in 2023, we are much more advanced. If you see the executive summary of AHRQ, again, historically, lumbar puncture was mandatory. And this was based on the studies done in 1980s. And here also, they told that lumbar puncture may be omitted for well-appearing, previously healthy young infants. Why? Because earlier, the strep pneumonia, HIV was contributing to meningitis a lot. Now, because of vaccination, these all diseases have come down much significantly. They are not a great number nowadays. So testing has changed. Now we have ProCal, we have CRP, ANC, in addition to the clinical criteria. Earlier it was mostly clinical. Now we have these things to guide us. But there is a scare among doctors that अगर LP miss हो गया, so what? So जो डर गया समझो मर गया. That is a scare that आगे meningitis miss हो गया. So extra tests are done. But this is important. That scare actually cuts the clinical decision-making hands. That is the Gabbar in Sholay. We have our hands, and this scare and anxiety that we are going to miss a diagnosis and do unnecessary invasive tests on a well-appearing child, it actually cuts the clinical decision-making hands. And this is well known that treat the patient and not the test. So our decisions should be not based on flipping a coin and should not be real life decisions, but real making decisions which should be based on evidence and rational. And this only when they go together will be able to solve. Now new guidelines have come. She has also, Dr. Supraj has told that CRP, ProCal and urine district based on the total scores, you can classify an infant between 0 to 3 months of age as 1 to 3 months of age as low risk and high risk. And within high risk, then you can go for further testing if required, not mandatory. Then there was a step-by-step modified, which is discussed in 2016, when they define high risk as not well appearing, 28 days or less, of this leukocyturia, urinalysis, or ProCal, or ANC. If none of this is there, that is low risk, you don't need to go do anything. But if it is high risk, you can consider it, but not mandatory. The pecan criteria, again making things more simplified. They told a febrile infant with positive urine test and an ANC of around more than 5,000 and a ProCal of more than 1.7, you can classify as high risk and low risk, no need to do much. These are all 2019 guidelines. So this is from the Canadian Journal of Medicine, which says that systematically performing a lumbar puncture for work of a fever without a source of infants appears unwarranted given the low prevalence of bacterial meningitis in this population. So do LP just because it was there in the guideline, and we should not do it because now it is not there in the guideline, which says LPs are not typically needed in evaluation of fever in these events. However, if there is a positive biomarker, then shared decision making may be useful in LP decision making. So again, even if they are positive blood markers, still you need to be careful. So this is what the AP has told, that I will live in the past, that I have to learn from the past, but I'm living in the present and the future, and everybody will teach me what I should do today. And that is what they are being told, that LP is not mandatory. Follow your clinical decision as well as your laboratory parameters and come to a conclusion. This is again from the latest 2023 guidelines, which says that unnecessary tests are being done world over. It not only is harmful for the patient, harmful for the family, but sometimes false positive results come and the infant is given unnecessary antibiotics. Unnecessary hospitalizations are done, and iatrogenic hospitalizations happen. So costs are definitely an important factor. And it is important to learn to do something called as safely do less. You don't have to do more. You have to safely do less. And the prevalence, as already told by Dr. Supraja, in this age group is 0.1%. That is too less. And the discomfort to the infant, respiratory compromise, traumatic LPs, unnecessary hospital stay, unnecessary prolonged stay, substantial cost, parental anxiety are things which should not be neglected. And it's just shared decision making, not a mandated decision making, and that is after you think the patient is clinically and laboratorically sick. So this is the simple way to put across. May have a lumbar puncture in an infant 29 to 60 days if they have abnormal inflammatory markers. This is again the same. If the patient has any of this temperature more than 38 or procal, yes. If the urine analysis is negative, then you perform a LP and do a CSF and treat accordingly. The graph is very, very simple, not complicated at all. Multiple guidelines again have said the same thing, that do not perform LP, do not perform LP until it is indicated by raised inflammatory markers. At admission, you will send urine analysis, blood culture, and inflammatory markers, not LP. So if urine analysis is positive, do not do. If blood culture is positive, you may consider. Inflammatory markers are positive, you may consider. Just to highlight the difference between the ARP inflammatory markers and the PCAN inflammatory markers. PCAN is much more simpler. They don't give importance to temperature, whereas the American Academy gives importance to temperature, and the difference of adding CRP in the American Academy of Pediatric Guidelines. Then if you see the fever without source guidelines, the international guidelines from 2013, 1993, 21, all have been compared. And this is what they say. The blue one says LP is mandatory in a well-appearing child. So the blue one is this, recommended to perform all irrespective of clinical condition. That is less than 1 month. 1 to 3 months, it is all red. Red says recommended to perform LP with a high risk of serious infection, not with a low risk of serious infection. So it is very much clear. All guidelines world over have shifted their stand. They are saying that do LP if there is a high risk infection. And this is from the Indian Academy of Pediatrics. In 2017, they published. There was a mistake over here. If you say 29 days to 90 days, they mentioned lumbar puncture here. So this created a lot of confusion. And 28 days, it was actually a printing error which got corrected. In 28 days and less, lumbar puncture is there. But 29 days to 90 days, no lumbar puncture. It is not even mentioned there. So we have to understand that we have changed, epidemiology has changed. So keeping it simple, we are discussing 29 day to 60 days. Urine analysis is important. Blood culture you have to do. Inflammatory markers become important. CSF is a maybe, not a mandatory. Antibiotics is a maybe. Whereas in a neonate, it is definitely mandatory. So this is from the same movie, surely trying to relax the moment, that once you have everything, you have your NICU, MR puncture, CSF, you have your targets to achieve, but that is not right. Your target should be evidence. That is what Shashi Kapoor is saying to Amitabh Bachchan. So just to end it, practice point, PCAN criteria is very helpful. ARP criteria is very helpful. Then there comes the philosophical basis, that there is a philosophical chance that you will underdiagnose and undertreat a disease. But we are not here practicing philosophy. We are practicing medicine, and which has to be evidence-based. So do LP when indicated, not mandatory, and do your evidence-based practice, not philosophy. Don't be a strict gubber in your ICU doing a mandatory LP in a 2-month-old, but be the right Thakur and decide regarding evidence-based LP in a 2-month-old baby with fever. Thank you.
So please unmute yourself. Subbarao sir, please unmute yourself.
Thanks for a wonderful real based argument, and with lot of full stops and punch marks. I'd like to request Supraja if she's got anything in rebuttal.
Yes, I would like to go back to the slide where I put the glass and said half empty, half full. We both are looking at the same glass. We've just said it in different ways. I think both of us have reinforced the same point in a debate. I would do the LP in a less than 2-month-old baby only in high-risk criteria, and that beautifully Maninder has pointed out, and we both would do the LP in less than 1 month old. So I think just for the debate's sake, we've had evidence put on different platforms, but we both agree on the same.
Yeah. Finally, the adjudicator's remark is both debaters have agreed to disagree and disagreed to agree. But the bottom line for the audience is yes, we have to have certain clinical basis for deciding, supported by appropriate laboratory evidence. And in any given case, I'm sure Jagdish will tell, oh, this child, I think we should do LPA, and then we'll do it as an individual. Experience also adds into the philosophy. But by and large, we agree that we not make it mandatory and do it as based on guidelines. Thank you very much for the opportunity. Any questions from Jagdish or others?
Only one comment, and I think the demography of children that we see in the West is very different from what we see in India. And especially the vaccination status in our country, especially against pneumococcal vaccine, is extremely not very widespread, especially in the rural areas. So I think the point is that it has to be an individual decision making in our country. It cannot be standard, because at the end of the day, the whole child population in our country is diverse and in different areas. So I think the important thing is to have a high index of suspicion. Don't go only by your clinical markers, because we know the quality of laboratories in most places. What is the absolute neutrophil count? What is the CRP? What is a procal? And many of our patients can't afford to do all procal and whatnot. So I think the important thing is to look at it clinically. More than the clinical suspicion is more important than anything else. Of course, the other very important thing is that when you are faced with a child with a fever, you probably need to see that child again within a few hours to see whether you are on the right track or not, because a single observation is not going to help you make any great clinical decision. So I think repeated reevaluation clinically, going by some red flags, and of course, where it is possible, maybe Amrita Institute, maybe the hospital, maybe Manipal Hospital, we can do all the ANCs and the CRPs and the procals. But I'm sure that most of the people practicing in other areas would not do any of this and go strictly according to clinical criteria. So I think we have to give way for a wide variety of patients we see and take it from there. So thank you, both of you. I think both of you brought out very important points and they are wonderful. Thank you.
Thank you. The other point I would like to emphasize is that one case of missed meningitis might face serious subsequent consequences. So it is mandatory that we keep our options open. And what they say is our mind is like a parachute. It works only when it is open. So keep your mind open, and then maybe we'll save many more lives. Guidelines are only guidelines. They are not mandatory. So we should use it as a guideline and modify it according to our local needs. Thank you very much, Dr. Supraja and Dr. Maninder. And I thank the Fever Foundation for giving us this opportunity. Over to the organizer, and wish the Indian team all the best for their they're chosen to do batting first. Australia won the toss and they've asked to bowl.
And incidentally, first boundary, sir.
Okay, thank you.
Thank you, sir. Thank you, Subbarao, sir, for sharing the session and being the educator for the final session, the pro-con debate. Thank you, Supraja madam, and thank you, Dr. Maninder, sir, there for the wonderful rebuttals and the pointers there with the multiple clinical endpoints and takeaway messages. Thank you very much. It's been a fantastic scientific feast for the past 3 days. The FEFCON, the 6th Annual National Conference. I think we have come to the end of it. We had a wonderful 3 days of session. I think to do the concluding remarks, I hand the session to Mr. Praveen Singh. Before that, I would like to have a couple of minutes of talk from our organizing chairperson, Dr. Jagdish Chinappa, sir. Then I'll hand over the session to Mr. Praveen Singh.
I'm going to have only one sentence. Thank everybody for the fantastic sessions, and move to Praveen Singh quickly because I want to watch the match.
Thank you, sir.
Yes, sir. I'll make it very quick. First of all, respected delegates, speakers, chairpersons, and I'm honored and privileged to have witnessed accelerating scientific feast in the last 2 evenings and today. Fantastic sessions, and everything went. It was more like having everybody, the speaker, spoke not like just the lecture, but they were really having fun while and the discussions, debates, and fantastic. I mean, like every year, the bar has been raising, and this year too, it has gone one notch up. So I thank all the speakers, chairpersons, and all. And also, I would like to thank the advisory board members who have been, available for us at any given point of time, give suggestions, and come out with such wonderful program. I still keep wondering that, how is it that, we are so blessed to have such wonderful ad board members who keep, inspiring us, who keep coming up with such brilliant ideas and brilliant topics. We are blessed to have worked with such esteemed ad board members and the speakers and the delegates. Further, I would like to thank all the 60,000 doctors who have registered for FEFCON. So most of them, they say that, they will not be able to attend, but we want to register, because having registered, we are going to get the soft copies, we are going to get the books and all. For that, we have to. So in that sense, FEFCON is very, very popular. And like me and like us at Microlabs, most of the doctors are waiting for a physical conference to happen. And one request that most of the doctors had was that, they want to have state FEFCON. This has been a repeated request. So I am sure it is going to be something that we have to take up in the ad board meeting, sir. And next, our medical team headed by Dr. Manjula. Thank you very much, ma'am, for guiding us and coordinating and putting everything in place. And Dr. Krishna, I don't have words to praise Dr. Krishna, because, he is such a silent worker that, being in the same floor, I do know that, how much of efforts Dr. Krishna is putting and all those things. Hats off to you, sir. You are the, the spinal cord, or you are the backbone of all the activities at head office regarding medical, as well as, of course, FEFCON 2023. Further, I would like to thank Mr. Jairaj for being good support always, and Mr. Girish for being there, and all my field force who ensured that, we reach to more and more, FEFCON reaches more and more, to more and more doctors. And looking forward for all of you, looking forward for meeting all of you in our next FEFCON, that is 7th FEFCON 2024. Thank you, and have a great evening, and God bless all of us. And please take care of yourself. You are more precious than anybody. You are for the country's health, you are very important, and you are more precious than anyone in the country. All the best.
Thank
for
you.
India team. Thank you, sir. Thank you. I'm privileged.
Thank you, Praveen. Thank you. Thank you for your nice word. Thank you. Thank you, everyone. Thank you, Jagdish, sir. Thank you. Thank you.
Thank you. Thank you.
Recording stopped.